Hi everyone, this is Mia Dan. I am the host for today's event. We're just getting started, just giving folks a few minutes to get in, settle in. We have a very packed agenda and we will be going for 3 hours straight, so we won't have a chance to take too many breaks, but please do grab some water, stay hydrated, or grab your favorite drink. And if possible, please try and keep stretching throughout, whatever you're comfortable with, but please, we do prioritize self-care here. So just wanted to make sure this is your friendly reminder. So we'll get started in about a minute. I will be introducing our event for today and also what you can expect for the next 3 hours. So without further ado, let me just make sure I can share. So today you are at Building Inclusive, Ethical, and Accessible AI for Healthcare event. We do have captioning to make sure for folks who need the captioning options that you can follow along. We do believe in a world that's inclusive and ethical and accessible, especially when it comes to AI. So today's event is supports our mission. This is a shill-free, spin-free zone. We don't do any ethics washing here. We also do not have any corporate sponsors for today's event. So I'm so grateful for folks who showed up, folks who donated, because we are funded by ticket sales. Today's hashtags that you'll be using, if you're on Twitter, are AI Healthcare and Women in AI Ethics. Please do tag Women in AI Ethics if you have any questions or if you'd just like to be part of our community. So who am I? I am Mia Dan. I am the founder of Lighthouse3. We are a consulting firm focused on ethics and governance of emerging technologies, and believe in guiding companies on responsible innovation, but on scale. We believe in making artificial intelligence and all emerging technologies more accessible, more inclusive. We believe firmly in a diversity-first approach, and that's what you'll see reflected in Women in AI Ethics, which is also founded by myself, and it is a fiscally sponsored project of Social Good Fund. And it is a California-based nonprofit, and I too am based right here in California, as is Lighthouse3. So how did it all get started? We will go into the long version another time, but the short version is it all started in 2018 when I published the first 100 Brilliant Women in AI Ethics list. And it received a lot of support, and believe me, I could not have done it without the support of the community. And it is so important for us to recognize the women who often go unrecognized, underappreciated, undervalued in this world. So this is my contribution and our contribution to making sure that we are making the world of AI more ethical and inclusive. And after the great feedback we got to the initial list, the Women in AI Ethics organization was formally created to increase representation, recognition, and empowerment of women. We don't believe the lack of representation is a pipeline issue. As you'll see in today's event, we have so many amazing women who are joining us today. And we don't believe in inviting women just to talk about diversity. We want to see their amazing work. And that's what we mean by representation. We have an online directory, and you can nominate yourself. Yes, there are links. Our moderators will put the link in the chat. Over 500 women, over 15 regions, and it continues to grow. With your support, I am confident we will double that number by end of this year. We have hosted many events, and as you can see, our events are diverse and very supportive of each other. We do believe in lifting each other up, which is why we are so grateful for this great community that we have built. This was our last event. As you can see from the faces and the diversity, we had every dimension of diversity represented. We even had not only by BIPOC representation, but we had regional as well. 3 of our sessions were in Portuguese and Spanish. So we do walk the walk when it comes to diversity. There are many, many ways you can join us. You can support us by donations. You can stay in touch with us through our newsletter. You can nominate yourself or a peer for our directory, and all the links will be provided to you. And please come join us, volunteer. We're always looking for volunteers as well. Okay, so for some reason, okay, let me just go back. We do have a great newsletter. Let me just go back to sharing. Hopefully I'll be able to do this. Okay, give me just a quick second so I can go back. Okay. Just a second. All righty. Okay, in the interest of time, I will keep going. This has never happened to me before, but I'm having some sort of technical challenges. So very simply put, today we are here to celebrate and recognize women who have been doing a tremendous job in this event. And we do want to make sure we give them enough time to share their expertise. So without further ado, I would like to introduce our panel and the event for today. And we have, let's use the agenda. But first, I just have a few ground rules. We are a women-centered group, but we do support non-binary, LGBTQ, BIPOC, and disabled members. We believe trans women are women. We respect everyone's right to choose their own pronouns. Please do add pronouns to your username so we can also make sure that because we do believe that you have the right to do that, and we want to support it. We have zero tolerance for any hate speech, any form of harassment, bullying, or discrimination. We're all here to learn. We are not Facebook, we are not Twitter. We're here to be kind to each other, so please follow those rules. Big thank you to all our volunteers who made this event happen. We could not have done this without your help. Samaya, Anne, Katrina, Sharari, Lisa, Jasmine, Susanna, Ray, Lavina, thank you so much for being here. And they will be are the force that keeps us going. Here's the agenda. We have 10 minutes of opening remarks. I will hand it off to our first panel moderator, Deborah Rue. After that, followed by another great session led by Chavi Chauhan on AI and mental health. We also have ethical AI and healthcare perspectives, East and West by Ashi Tandon. So I do want to give a big shout out to some amazing women, which is Chavi. Thank you so much for your leadership, bringing this group together, for organizing this event. Deborah, fantastic panel that you have lined up for us. Thank you so much always for being so incredibly supportive and champion for the cause. And Ayushi, I know it's very late for you, but thank you for putting together such a brilliant panel. So with that, I will now hand it over to Deborah to introduce us to her panel. You will have to unmute yourself, Deborah.
Somebody had to be the first to do that. So I guess it would be me. So thank you so much, Mia. Thank you to you and your team and Shavi and everybody that's here. I love women supporting women. I just think it is so critical. And I also love that we're really focusing on these issues, looking at the diversity lens as well. So this is a very diverse panel of amazing, talented women. And I'm just really proud to be part of this. So I'm just going to tell you a little bit about each of my panelists. And then in the first question, I'm going to have them tell you a little bit more about who they are and what they're doing. And what I'm also going to do is I'm going to start with Rachel, then I'm going to go to Frances, then I'm going to go to Rosemary. And these are really amazing women in their field that are changing the world. And I love standing shoulder to shoulder with women that are changing the world. So once again, thank you to Mia and to Lighthouse3. I love the work that's happening here. So first of all, I'm going to start with Dr. Rachel Hendricks Styrup, excuse me. And can you tell us a little bit about the work that you're doing with the Health Policy Council, and also a little bit about yourself? I know you said you have a 2.5-year-old, so we'll start there.
Absolutely. So I am the Health Policy Counsel and Lead at the Future of Privacy Forum, which is a think tank located in Washington, D.C., where we help bridge the divide between academics and corporations and others like advocacy organizations as well, to really come to the table and talk about the future of privacy, which in fact, I think we can all agree is not just privacy. We're entering a future of a whole set of things that or a set of challenges even that involve certain uses of our data as it's generated and collected across a multitude of settings, including healthcare, which is my vertical at the organization, healthcare and genetics, actually. And it's my pleasure to lead the work there at this organization. We've done a lot of wonderful events like this, and we continue to support events like this through our participation and in other ways. And we have a lot of exciting things planned for this year, post-COVID, like most of us here. So very excited and very happy to be here. And yes, I have a 2.5-year-old, and I have a spouse who almost feels sometimes like a 2.5-year-old as well. And so lots of, caretaking on my end, but also lots of fun. So very fortunate, to have both of them, in my life on the day-to-day.
Yes, thank you. And thank you for your work. I forgot to mention to the audience that we're going to speak for about an hour, and then we're going to have 15 minutes of Q&A. So please think about the questions you want to ask these really brilliant women here. So we wanted to make sure this was very interactive. I know all of the training and panels and webinars that they do, they always make sure that the audience can participate. So that's important to us as well. So thank you. Thank you, Raquel. Frances West has been a friend for many, many years, and I just love working with Frances. Frances was the first woman to be named Chief Accessibility Officer for IBM, for any corporation, but at IBM. And she is also the author of Authentic Inclusion, which is an excellent book. And she now is retired, and she doesn't obviously understand what retirement means. And so she went and she created another company, and she's Frances West Co. So Frances, welcome to the program.
Well, thank you, Deborah. It's always fun to be with you, any panel. And when you call, I will come running. Like Deborah said, I was a corporate person with IBM for 30 some years, and I held many different jobs. But my last job was at IBM Research and heading up the Human Ability and Accessibility Center, and turned out to be a life-changing job in that I was able to work with a tremendous talented team, consists of all kinds of a person with disabilities, from deaf to blind to cognitive disabled, and then to see the innovation that they create for not just for IBM, but for the world. So I carried that kind of a sense of mission and conviction actually into my post-IBM world. And so now I work with private, public companies and the government agencies like the UN, and also very exciting area with startups to make sure that they understand that diversity we're talking about here, or accessibility, is not just for a few people with disability. It really is innovation that matters. So it's been an incredible journey. I tried to follow Deborah's, kind of entrepreneurship and thinking and way of doing things, and I'm learning every day. And again, it's such a pleasure to be among the sisters and to really try to influence this very important technology called AI, here and now. So thank you again for the invitation.
Yes, and well said. And also thank you for supporting entrepreneurs. We all have to support each other. And I know those of us that are over a certain age like me, I think it's becoming even more important that we have a legacy, and we make sure that we are opening the doors so our sisters and our brothers can join us. So thank you. Thank you.
Well, can I add that I will have 3 granddaughters by June?
And I have none, so congratulations. I'll try not to be too jealous, but probably not going to happen. So, and okay, so our next guest, certainly last but not least, is Rosemary Mustachio. And Rosemary Mustachio, I'm really blessed, is working with my firm, Rue Global Impact. She's our Chief Accessibility Officer. She's also an author of a book of poems that will be published in the next couple of months. She's a very, very talented poetress, and she's also a very talented writer, and I think one of the best minds in accessibility in the world. Rosemary was born with cerebral palsy, or actually she acquired cerebral palsy as she was being born. And Rosemary, she told me one time that when she lies down flat, she can only blink her eyes. But do not underestimate Rosemary. And once again, kudos to Mia Dan for inviting Rosemary to speak, because sometimes people are afraid to invite amazing, talented speakers like Rosemary because she's using technology to have her voice be heard. So I think it's very, her voice needs to be heard. She's adding so much value to the world, but I appreciate conferences that are making sure we really are talking about inclusion in the broadest sense of the term. So Rosemary, welcome to the program. Do you mind telling us a little bit about your background and the work in the accessibility field?
Thanks very much, Deborah. I'm honored to be on the AI and Healthcare panel with you, Francis, and Rachel, outstanding science and technology leaders. I had no idea I'd be in the accessibility field when I graduated Cleveland State University. I wanted to be a journalist and a public relation writer. In fact, I wrote a monthly column in a local newspaper and some editorials. But that didn't earn me much, so I searched for other opportunities. In 2000, an ad in a disability newsletter jumped out at me about this company called Tech Access, founded by our gracious moderator, Deborah, calling for accessibility testers. So I applied, and Deborah saw something in me, God knows what, and hired me. Tech Access taught me the basics about accessibility testing. Besides accessibility testing, I also did business development, training programs, and newsletters. 2 companies, and 15 years later, Deborah wanted me again at her new company, Rue Global Communications, which is now Rue Global Impact, where I'm currently the Accessibility Chief Officer. Besides performing accessibility audits, I write blogs. I also conduct accessibility reviews for a legal firm in California. In my spare time, I write poetry. Hope to publish my first book this year with the help of Rue Global.
Thank you, Rosemary. And those are some really beautiful earrings you're wearing too. I got to do a little compliment there. Now, Rosemary is using what we call a head crown, a head pointer. And it is considered a little bit older technology, but sometimes you just really get used to certain technology. She also uses eye scan technology. But just because Rosemary does not communicate in the same way as other people doesn't mean that she's not any less brilliant. As a matter of fact, she has worked on some of the biggest accessibility legal cases in the United States. So she is being very humble when she said, I don't know what Deborah saw in me. I saw brilliance, and I saw diversity, and I saw that she probably was going to come at these issues in a very different way, since her life is different from others. And so we appreciate you, Rosemary. So thank you. Okay, back to Rachel. So Rachel, or Rochelle, sorry, can you give an example of how AI is used in healthcare settings today?
Sure, absolutely. Well, first and foremost, you can say either Rachel or Rochelle. Actually, I have
Thank
both names.
Sorry.
My mother is of French origin, so I have the French spelling of Rochelle, or of Rachel rather. So Rachel or Rochelle is fine. So to answer your question, AI is being used, or artificial intelligence is being used in lots of different ways today in healthcare settings, whether it's through the use of a chatbot, like an artificial chatbot. Say if someone is experiencing symptoms, you can chat with some computer or robot online over text message, through other types of communication channels, depending on if you have an account with one company that offers this channel versus another company that offers another channel. You can speak with like nurse bots in that sort of way to sort of allow them to screen your symptoms to tell you whether or not you should go see a doctor or give you some type of recommendation about what you should do next. So AI has, that's one way it's being used. Another way is through the use of ambient charting in healthcare settings where as physicians increasingly need scribes to sort of transcribe the conversations or interactions that they have on the day-to-day with their patients. There's ambient charting that sort of collects the voices being heard and then jots it down on a paper or in a electronic document. So that's one way. And then not artificial intelligence, but definitely within the scope of it with regard to machine learning. That's being used a lot in radiology as a way to predict based on an image whether or not someone may have a certain diagnosis, like for example, breast cancer. AI and machine learning can be deployed on these images to determine if someone is at stage 2, 3, or 4 metastatic breast cancer, and thus not necessarily diagnose that person, but serve as an aid to a physician that would make the diagnosis for the patient. So those are just 3 examples, really high level examples that we're seeing today across the field, or at least across specialties in healthcare.
Yeah, great answer. Thank you. Following that line of questioning, Francis, how is AI impacting healthcare inclusion and accessibility, especially during the COVID-19 pandemic? But you can speak to this in whatever time frame you want to.
Well, like Rachel says, I think the artificial intelligence is just coming onto the scene in that it's learning to communicate. One of the form, like Rachel said, is through these kind of a chat box, but we can also see that it's beginning to get used in, for example, communicating with people with, for example, mental health diagnosis, and do some kind of a self-assessment, because mental health or mental disability sometimes is a slow onset, and that if you can use technology via some kind of app to record your routines, or have the app, kind of remind you, a certain even a certain behavior difference, that hopefully you yourself will be more of a self-aware of whether you need some kind of interaction or intervention, right? And we also have seen technology in I think the most famous kind of articulation is like care robots like Paro, this little cute, seal looking, almost like a stuffed animal that can talk, or interact with the elderly when they are in social isolation, to kind of simulate a human behavior or human dialogue. So these are all positive use cases, how AI can be applied, especially in a COVID, in a socially isolated situation. It certainly cannot substitute human, but at the same time, it's better than not having anything. And also, this is the beauty of artificial intelligence, that is as we use it more or talk to the robot more, it will learn, and hopefully over time, the conversation becomes more relevant and meaningful.
Yeah, and speaking of that AI seal, one thing that they figured out that I thought was very interesting was they brought it into nursing homes with elderly patients, as you said, Francis, and But what surprised the researchers and the scientists was the elderly person would be playing with the seal, and other human beings, family members and friends, would get curious, and they would come over and they would start asking the person about it. So it wasn't necessarily the AI that caused the engagement with other human beings, but it was because of the novelty. And so we know that humans will still need to be very involved, with the AI to make sure that we have the biggest impact. But I also thought that was a great example. Now I want to dig in just a little bit more. Frances and Rachel both explained, some of the things we see out there, but let's talk about it a little bit more from healthcare, from a personal perspective. So Rosemary, I'm going to ask you the next question. Have you ever been in a hospital or healthcare situation where you were not given good care because you have a disability? And of course, we're looking at this from the lens of how AI and everything can help. So Rosemary, the floor is yours.
There have been numerous instances where I felt subhuman during hospital stays because I could not communicate, and nurses and other medical staff did not have time or patience to try to understand. They also may not have been trained to interact with nonverbal patients. For example, in one hospital stay, the IV came out of my arm, causing my arm to swell up and become blue. I tried to show the nurse by lifting my arm, but he did not get the hint until he actually saw the IV line. Then he blamed me for moving my arm. Other times I kept yelling because I needed to go to the bathroom or I was slipping down the bed. Nurses walked by my room without coming in. When someone would finally come, my eyes would look towards the pillow indicating I wanted it under my head, or I'd point to my pubic area indicating I wanted to urinate. Even then, sometimes they could not understand me. Once a nurse came in and told me to shut up after I've been yelling that I needed to use the bedpan. One other example is I'd accidentally pressed the call button when I was targeting the button to change TV channels. So the nurse removed it from my reach. These incidents show nurses assume I did not know any better or that I just wanted attention. If I could talk, they would not assume this since I could tell them what I need. Not all my hospital experiences have been bad. However, ER visits have been very accommodating. When I go to ER, I usually bring an information sheet that includes how I communicate. So ER staff have been very attentive to my needs. They have treated me humanly, taking time to understand my ocular and vocal cues. The information sheet is supposed to go with me if I get admitted, but often nobody adds it to my chart.
Thank you, Rosemary. We're getting some shocked responses from the panelists, and I think we are all shocked because the reality is just because Rosemary is nonverbal doesn't mean that she is not intelligent. So it's really, these conversations are so critical. You have the doctors and the scientists and the leaders, but the reality is it's not getting to the people that need it. It's not getting to the healthcare professionals that need to understand that. And the reality is, when Rosemary is nonverbal, but often when we're in an emergency situation, I know sadly I have a husband that's in very late stage dementia, which is chilling, and he's lost his communications. He cannot communicate with people. So, I'm going to upset Rosemary because I know how much she loves him. I'm sorry. And me too. But the reality is, when our loved ones and ourselves are in hospital settings or healthcare settings, artificial intelligence can be a very, very big help to us. But at the same time, we do have to understand what the patient experience is. So thank you, Rosemary, for being so honest with us. Rachel, what are some important questions to ask in regards with the ethical use of AI in healthcare settings?
Absolutely. Well, this is a hard, act to follow after Rosemary's story. I think her story sort of states the obvious answer to that question. How should we if anything, leverage AI in ways that perhaps can enable those who might have a disability or a disadvantage in terms of, the more normative ways of communication that a lot of people are used to, but and also the most tolerant of, I guess you can say, as Rosemary mentioned, she carried a card around to say, this is how I communicate. These are the, technologies that I use or may not use to do it. If AI can come into the picture and, augment or facilitate communication between those who may not be able to communicate, like everyone else, and that applies to people who even have an ability to speak. Just because you can't necessarily communicate in one way doesn't mean you can't communicate in another. If AI can be used in ways to help people clarify the points that they're making, or help individuals convey an idea or a thought or a feeling in a comprehensive way that is understandable, to facilitate the appropriate action, especially in healthcare settings where appropriate action is necessary. This can be life or death in many cases. AI should really come into the picture for those types of situations, in my opinion, and also in other ways as well, in order to make sure that we're not using AI to perpetuate biases or discriminatory practices, but rather leveraging it in ways that empower individuals, regardless of their condition or situation or circumstances. Deborah, you mentioned that your husband or your spouse is in late stage dementia phases. My grandmother actually passed from Alzheimer's. So I understand the difficulty in communication. Not to say that AI can cure, dementia or Alzheimer's or other conditions like that, but if there are people out there thinking about applying AI technologies in this type of way, not necessarily as a cure for something, but rather as something that can be used to facilitate stronger communication, I think that would make a huge difference, because a lot of times conditions or anyone's condition, physical, mental, or otherwise, can be exacerbated when they are in stressful situations or circumstances where they are not being seen or heard, and then subsequently their needs are not being met. And that just worsens the situation. It has a snowball effect that benefits no one. So I think we really should think about the development and uses of AI in this type of way if we really want to make a strong impact for ourselves and our communities.
Well said, well said. I've spent so much of my career talking about technology is so wonderful, but we have to humanize it. And let's stop deciding certain members of our society don't add value. Say women, for example, which we're the largest minority, which is confusing to me since there are more women in the world than men, but that's a whole nother thing. So, but well said. Francis, let me go to you next. What role does intersectionality play in building inclusive AI for healthcare systems?
Well, I think the AI as a technology, it's like we talked about before, it's in such a beginning stage. And so it's actually full of promise, in the sense that leave it unattended, of course, and then potentially it could be just, I would say, continue the kind of the thinking in the past decade, which is, let's build something to the majority. It's almost like, look at the bell curve, just look at the middle part where the most people can benefit from it. But the beauty of something like the artificial intelligence technology is that because it's technology, you can, if from the beginning, that you build logics, because artificial intelligence is built upon machine language logic and then data sets. A lot of times I hear people say we don't have enough data sets out there for people with disabilities. But one can imagine that the technology is evolving so quickly that each person could have its own data set. In other words, if we start accumulating data from the individual, because like I mentioned, I have granddaughters now, and from the day that she was conceived, and you will see these, what do you call the ultrasound pictures, right? So there's a digitization from the womb, right? And one of the last, if I stay on in IBM longer, and one of the projects we were exploring is a lot like My Life, My Data. I can imagine that, for example, the data set that make up, your environment and your communication or your style of living for Rosemary is very different from Deborah, is very different from me, and it's different from Rachel. But one can imagine that the AI could be deployed in that kind of setting to understand the contextual differences of us and be able to support us. And then, so that's a kind of a far-reaching kind of a scenario. But in the near term, I noticed that John Rockford is in the audience, and one of the near-term project we worked on when I was at IBM was text simplification and summary. So think about when you go to, hospital, when you're getting discharged, you get all these rims and rims of a paper and information. It's just so daunting. It's like reading a legal document, and many of us just like in shock. Wouldn't it be nice if somehow then AI can take that information and based on your state of mind, hopefully, or your state of age, that can, transform that information to your level of ability. Those are kind of things the machine actually can do if we program it into that. So from that standpoint, today's AI is, because it's a beginning stage of a new technology, is built to the masses. But I'm hopeful that through conversation like this, that all of us can keep, challenging the technologists to put what I call the human first thinking in there, and then use these very edge cases. Again, going back to the bell curve, you can think of the edge cases, but the edge cases or edge computing, the last mile actually is the most important mile or the most important people. So if we can build to that with that kind of logic in thinking, we absolutely can then create a better, just and fair and ethical world as everybody, is spouting and wanting to do.
Well said, Francis. Now you can see why we invited these women to this event. Rosemary, next question's for you. Communications issues impact people with disabilities' efforts to get good care in the hospital and other healthcare situations. How can we improve these problems?
3. Communications issues impact PWD efforts to get good care in the hospital and other healthcare situations. How can we improve these problems? Many techniques and tools can facilitate communication between nonverbal patients and hospital staff. Some individuals have voice synthesizers, such as the eye gaze, where they activate words and letters by looking on a computer screen by a couple of seconds or blinking. These devices have to be positioned correctly so patients can access them accurately, especially if they are in bed. Family members or caregivers can help set it up. If the patient does not have a communication device or becomes nonverbal during a hospital stay, the hospital should have communication devices or iPads with communication apps. For instance, the Icu Communicator for iPads. Not only does the app help nonverbal patients, it also helps patients who don't speak English and or are hearing impaired. The app has screens showing body parts, pain levels, and needs. Someone may point to the knee image or the phrase, "I need to use the bathroom," on the app screen, for instance. Conversely, if the patient is deaf, a medical provider can point to images of different body parts or pain levels on the app as to ask them basically, "What's bothering you?" Another hospital communication app is Smalltalk Intensive Care. It has icons with associated phrases such as "I have chest pain" or "I feel weak." Sometimes patients do not have enough motor control to point to an image or face on an iPhone or iPad. That's when picture or word boards with the same content for apps may serve better, since they have more space for patients to point to. Pre-made boards also are available, such as Easy Board by Vedatic. The Easy Board has several versions, including ICU and EMS, with specific words and phrases for each hospital setting. For instance, the ICU boards include words describing a patient's state, that is cold, scared, and desires, that is to sit up. ICU boards also include a pain chart that includes words for pain levels, discomfort types, and personal hygiene. Each board also has the alphabet so patients can spell words. Since these boards are inexpensive, hospitals can purchase them for each floor unit. Even more primitive but effective communication methods involve deciphering gestures and facial expressions, such as repetitive gazes at something, pointing, even frowning. Returning to my IV experience, if the nurse could have figured out that my waving my arm meant, "Hey, my arm hurts and is becoming swollen," it would not be so bruised up. Studies have shown that effective communication by nonverbal patients can make them recover faster. For instance, patients spend 2 to 3 days less in ICU when they can express themselves more effectively. Patients become less frustrated, which lowers blood pressure and stabilizes respiration. Their comfort level also increases, since they can communicate if they are not positioned correctly in their hospital beds, for example.
Excellent points. I know I have a daughter that's going to be 34 years old. She still loves her birthdays in April, and she was born with Down syndrome. And the year 2018, we were in and out of the hospital, and my daughter can speak, but some people find her her accent, her Down syndrome accent, to be difficult to understand. I know Alexa struggles sometimes to hear, to understand what my daughter's saying to her. And so I just think the points that Rosemary made are so powerful, because my daughter, unfortunately, was in this really painful, terrible situation. And they had on the board that was across the room, these teeny little faces that were just black and white that I could barely see. And they were asking her to tell them her pain level, and she didn't really understand their charting. So we went, you know, this is what we do for a living. So we brought in a communications board and we taught them to use it, and it made it so much easier, because she was the patient. I wasn't the patient. She didn't want her mom talking for her. She, you know, she resents when people treat her like her voice doesn't matter. And I know that before COVID, Rosemary traveled often, and that would always happen to her. People that had questions would always ask her caregiver or her mom. Rosemary can answer, she can hear you, she can understand. I think just having a little bit more empathy and respect for each other would go a long ways. It's always very interesting to see doctors, for example, get into a situation where they're in a hospital and they start seeing how sometimes we're treated like we're, you know, not all human. And that's just a shame. So thank you, Rosemary. Rachel, some research has shown that AI can perpetuate bias in healthcare settings and can even engender misdiagnosis in certain racial ethical groups. How should this be addressed to ensure that AI can address rather than perpetuate implicit bias in a healthcare setting? I know this is a hard question, so good luck.
Yeah, that's a loaded question.
You got it.
You know, but before I get into my full answer, and probably as a preface to my full answer, you know, I think we have to remember that poor communication or ineffective communication has been the source of like all human conflict ever, in every space, in every place ever. So, you know, we can't technology our way out of that fundamental truth. So with that being said, with regard to perpetuating biases, whether it's regard to race or ethnicity, ability, gender, you know, the whole spectrum really of diversity, we have to think about when these AI models are trained, what data is being used to train them? What are any basic statistician or even someone with basic knowledge of you know, math even can understand, well, wait, if this model is trained on data that only reflects this type of thing or this type of setting, obviously it's always going to produce results or outputs that are tailored to that thing or that setting. So we have to remember that, you know, as we develop these technologies, as we create data to inform their development, you know, what is the nature of that data? I mean, what really baffles me is that, you know, the answer seems so simple, yet it's so difficult to implement in practice. You know, I think a lot of times when these technologies are developed, they run on, you know, move fast, break things type of culture where, you know, we have to get it out in the market, we have to get it VC funded, and we need to have a return on our investments. So there's less time to really think about the problems that this technology is trying to solve. There's more incentive to just, you know, get it out in the market as soon as possible and see what bites, without regard to the casualties that can occur, such as perpetuated biases, harm as a result of those perpetuated biases, especially if those technologies, those AI technologies are used in populations that it was fundamentally not built to serve or not built to represent. You know, we really have to really just get back down to the basics. You know, how can we communicate better with one another? How can we have inclusive design? How are we auditing ourselves around that? How are we making sure that we are using all the tools at our disposal to really reach broad and diverse audiences that may have various communication styles to inform us on the development of this technology or tool? How can we make sure that, you know, we are leveraging those communication tools to make sure that we are really effectively, you know, serving the most with what we have? Again, it all seems very simple when we talk about it this way, but in practice, for some reason, you know, it's difficult to implement. And I think it probably stems from the fact that, as I mentioned, the culture behind the development of this technology and also the incentives that drive their development are just misaligned with the communities that the technology either could serve or would serve. So I think we, again, going back to the table about humanizing technology, I think we have to first say, okay, well, this technology is shiny and new, it's great, but let's take a moment to humanize it a bit, and let's slow down if we can, you know, to make sure that we built this right the first time, rather than build it wrong the first time and clean up the mess that has occurred and the harms as well that have occurred as a result of our lack of attention to detail.
Yeah, well said. You know, do you have any, because I know that we talk about this a lot, making sure that, you know, we're looking at the right data, we're bringing in the right people, we're being heard, but there just seems to be, and even you were saying this, there's so many disconnects with this. How do we make sure that, you know, we are building AI and we're looking at it from the healthcare perspective, but that we really are, because it feels sometimes like, you know, we keep saying these things. I know, you know, Rosemary's been saying this her whole life. I know I've been fighting these battles as, a person myself with lived experiences of ADHD, and that causes anxiety. But as a mom, and now as a wife of my husband with a serious illness. But Rachel, what can we do to make sure that our voices are really heard? I understand there's a lot of things happening, including what Mia, Dan, and all this efforts are being made to make sure female voices are being included. But I know you're a scientist, a lawyer, and a doctor. What can we do? How can we do a better job of listening to what is being said? Why don't we solve problems that are there as opposed to problems that aren't there? Sorry, being a little sarcastic.
No, it's a great question, and I can say, well, first off, I'm not a lawyer. I am a legal scholar, but not a lawyer. I think that's a whole set of things. Yeah.
Legal scholar sounds more cool.
Lawyer to fight those battles. I fight other kinds of legal battles, but not the ones in court. But the answer to your question is, from a scientific perspective, I think that as scientists built these tools that are arguably informed by lots of quantitative data, we have to make sure that the qualitative or contextual aspects around that data are not lost. Oftentimes, as we punch the numbers and we really feed into the numbers, and then the numbers tell us this, the numbers tell us that, what have we done to understand the context around why we're seeing these numbers, or the context around describing, the context around what these numbers describe or say about our current situation as it stands, with all of its problems, with all of its with all of its even the good things as well. I won't just say the problems, but all of the benefits, all of the disadvantages, the double-edged sword that comes inevitably with progress. What is the data telling us within that context of what's going on today? And I think that there needs to be a stronger focus on what we call qualitative research. As a mixed methods researcher myself, doing both qualitative and quantitative, it's very, very difficult for me to draw conclusions solely based off of numbers. I really like to do the follow-up qualitative work, meaning that I go into communities, I conduct interviews and focus groups with these communities, so that way I can understand the context around what I'm seeing, and I can understand next steps that I should take and others should take based on these stories that accompany the numbers that we're seeing. And that's, I think, the root of social science. And if anyone argues otherwise, I would fundamentally disagree. We have to do a better job, even as scientists, with our communication skills. We can't just glue ourselves to our seats and crunch numbers all day long in Stata or Python or SPSS or whatever it is that you're using to quantify the information that you have. But we really need to exercise our own abilities to communicate with others as scientists who are trying to build technologies that we hope would be beneficial to the most or the greatest number of people within our communities, within our countries, globally, and so forth. So I think we have to challenge ourselves and look within and say, how can we be better communicators? How can we be more patient with those who may not communicate like we do? Rather than just take off with our assumptions based on what's in front of us right here. How do we not succumb to that availability heuristic as a behavioral bias that we innately have as human beings? How do we check our own biases at the door to make sure that we are being better communicators and not creating conflict, but rather addressing conflict before it can even happen in the first place?
I put this comment in the chat window, but I just feel so hopeful for the future because you are leading the charge. So that you give me a lot of hope. I also, Aisha, who she made a comment and I want to read it, but I also want to thank her for all the work that she did pulling this together too. She's amazing. And she says, thanks for raising these relevant issues about patients and people who have varied voices and communications abilities. My cousin's sister in India and her mother celebrate her abilities to cut vegetables on her own during COVID-19 lockdown. It was a moment of celebration in our extended family as Tika is born with asphyxia, and she someday has to eat, sleep, live on her own. Social support for differently abled in India are more important in the middle class society, and it's limited. I'm really hopeful that some trickle down effect of AI use cases in the West to the East and at affordable prices, contextualizing for India and other low-income countries, which is a really, really good point, because I know a lot of work that we do at Rue Global Impact, we want to make sure these things aren't just happening in the Western countries, in the US and the UK or Australia, but they're all, I guess Australia is not Western, but the UK and the US, for example, and that they're getting into the hands of the people that need them in India and China and other countries as well. So excellent point. Frances, let me ask you the next question. Do you believe that AI and other new healthcare technology can support inclusive telemedicine?
Certainly have huge potential, and it is probably the better potential for inclusion than any other means, because technology by nature is neutral, right? It's a neutral state. It doesn't have a built-in bias. If there's any bias, it's a built-in by human being. So from that standpoint, we actually are, in a way, starting at a very clean slate. I think AI really came onto the scene the past 5 years, even though it's been kind of in the research world for a long time, but the actual application of it really began to pick up speed in the past few years. So I think there is a huge window of opportunity for all of us. And since today we're talking about healthcare, I mean, healthcare is about healing people, humans, ultimately. I mean, that's what healthcare is about. And if you think about it, I'm actually very encouraged that we now have, I think, more women in medical school programs than men now, at least here in the United States. And then also you see, a university like NYU just did away tuition for their medical school students to take away the financial burden of future doctors. So that action alone potentially can do more for diversity than anything else. And you can imagine if we have more women or traditionally underserved population entering the healthcare system. And healthcare, as you know, is actually probably the fourth or one of the last industry that's embracing technology, right? The leading industry, obviously the technology industry themselves create the product, but then financial services is really the very much the next one, the retail industry. Healthcare is actually latecomers. So from that standpoint, we have an opportunity, especially for women, if we are in the position, whether it's administrators or physicians, to influence the makeup of the AI data sets or data logic and all that. I mean, you talked about my book. I mean, with all the technology time I spent in the industry, I walked away with two very basic concepts, which is we got to do everything to think human first. And second thing is, as technology gets more human needs to get more human. And I just think that this huge opportunity for women to create, for example, the next generation of care robots, right? Somehow having a guy develop a care robot just doesn't sound as, good as a woman creating a care robot, because women is a nurturer by nature, and it's not a judgment statement, but it's just natural, kind of understanding the differences of how men and women think differently, right? We use different logic. So I think this is again, a very, very exciting time. But on the other hand, we got to be very mindful to engage and to lead, not just cheerleading, because AI could be hijacked if leave it unattended, to become another super duper just for speed and efficiency. And like Rachel mentioned earlier, it's the qualitative, elements, the quality of life, quality of living, quality of healthcare that we have to strive for, because ultimately we're not dealing with a machine, we're dealing with a human. Human has feelings, feeling has, empathy that has to come into the formula.
Right, well said. All right, now I'm going to ask the last question to Rosemary, and I'll tell y'all why, because her technology is running out of power, her voice synthesizer, so we want it to be able to speak, but also it's going to be difficult for Rosemary to answer questions on the fly, even though she can use her head pointer to answer some questions. So I'm not going to purposely leave Rosemary out. There's just, unfortunately, technology limitations. So Rosemary, your last question. Why is it important for healthcare providers to have a chief accessibility officer or someone that's leading accessibility and disability inclusion efforts?
Thanks for testing this a cappella project. The evaluation period has now expired. You need to restart the computer to renew the evaluation period.
You know what? We got it. We got you back up, sister. We got you back up. Okay, here it comes.
Having a chief accessibility officer, COA, is vital for hospitals, clinics, medical offices, and dental officers. If a COA has a disability, it is an advantage because she or he knows from experience what patients with disabilities need to have pleasant hospital stays and quicker discharges. The COA should ensure healthcare providers have trained professionals to interact with patients with disabilities. By trained, I mean knowing nonverbal cues, low-tech and high-tech devices, and, most importantly, treating them with compassion and respect. The accessibility executive can establish training programs like SPECS2 communications training that covers everything from understanding communication needs to implementing communication strategies. In fact, these types of training programs should be mandatory. The COA must make sure patients with other disabilities are treated equally also. For instance, make all patient documents available electronically and accessible for patients who are blind, have vision impairments, or have dexterity impairments who have difficulty turning pages. Additionally, the COA has to think about patients who have neurodiversity disabilities, such as autism. Maybe make certain hospital rooms soundproof and softer lighting, not fluorescent. Medical equipment is another area for the COA to consider. A personal aside, a few months ago I had a CAT scan. Since my cerebral palsy makes my body move involuntarily sometimes, the X-ray tech literally taped my body, including my neck, down to the table. I was suffocating as I went through the narrow tube. So hospitals and medical centers must invest in open scanning machines where patients sit down in a small room and the machines accessible. Same goes for mammography machines. They have to be wheelchair accessible. Someday some brilliant engineer will invent the mammography bra. Wouldn't that be awesome?
And as y'all can see, Rosemary, she has wonderful expressions. I always know exactly what she's thinking and what she's whether she loves something or she's frustrated by electricity. Right, she does have great ideas. You're getting tons of love and accolades in the chat window, Rosemary, including, not to be a nag, getting that poetry book out. So all right, Rosemary, thank you so much. And Rosemary can type, short answers and stuff, but as you can imagine, it takes her a little bit longer to type something out than it would someone that was maybe using 10 fingers. So Rosemary, thank you. And sorry about the technology problems, but always glad we have a backup. So let me turn back to Frances. I'm going to go to you and ask you a question, and I'm going to say to the audience, we have, I'm being good at timekeeper. I have 3 more minutes of the main part, and then we have questions and answers. And so I'm hoping you guys are going to ask us some questions. And we have some that are in the can just in case, but we definitely want to hear from this brilliant audience. And I know we've talked a little bit about John, that John is on here, and he works in the hospital setting. So hint, hint, I know he's going to ask us some questions. Okay, so Frances, let me ask you this question. Can we use AI to help? And we've talked about this a little bit already. So Rachel, you might also want to comment on it, but can we use AI to help reduce stigmas in hiring diverse workforces in healthcare settings? So I'm sort of shifting it a little, but people with disabilities can add value all the way across the board, including in the workforce. And so hiring people with disabilities in the healthcare system, and actually people that have disabilities as part of the definition of disabilities through the lens of the Americans with Disabilities Act or the Convention on the Rights of Persons with Disabilities, I actually think we should really talk about our lived experiences in the same way we're talking about the gender conversations. Let's really own our lived experiences and want to talk about them. But Frances, let me give the floor to you, and then we'll pass it to Rachel in case she wants to comment as well. And then I say to the audience, we would love to answer your questions. Frances?
Yeah, absolutely. I think the fact that we now have a lot of mobile apps, based on AI, all the way from, for example, navigation help, right? Deborah, this company called Aira, they use their technology and AI to help low vision and blind people to navigate the world. But then because they augment the technology, it's almost like a Be My Eyes, I'm sure, like the Microsoft, a great innovation to kind of be able to go from point A to point B. So one can imagine, navigating the hospital complex could be, without a tool like that, it could be a little challenging, but, with a tool, it can be easy. And then also the technology could be used to help the person to, the whole workplace environment to, let's say, digest or to read out loud, some, let's say, charts that's not accessible, because we all know not everything can be made or are made accessible. But in the workplace, sometimes you have these pie charts or histogram that needs to be interpreted. So this combination of technology and human augmentation will be able to enable the people, in this case, the low vision or a blindness, to participate in healthcare. And I truly believe, just like we talked about women, because healthcare is about helping people who has some kind of, physical challenges. And so who better to understand or communicate, this is a theme that Rosemary so beautifully pointed out, than a person with disability. Their empathy, their understanding, or their foresight is just going to be that much better. So absolutely, I think that the technology, even the existing technology that's out there already, should be or could be deployed to help increase the participation of people with disability in the healthcare industry.
Oh, well said, Frances. Now y'all see why we invited Frances. We've been all following Frances's wisdom for a long time. So Rachel, sorry, but true. We got to love on each other, because it's really incredible, the people that are on this, the panel and part of this conference. These are the leaders that are changing the world. So let's be proud of each other. Rachel, did you want to comment on that?
Yeah, like, as you mentioned, I talked a little bit about that, and obviously underscore, everything that Frances said. I think we have to do a better job at being human. We have to look inward. We have to understand that we ourselves come into this world just inherently biased. as individuals. And I think we need to make it a practice every day to ask ourselves, you know, what have I done today that has not amounted to me only thinking of myself in terms of how I communicate? What have I done to allow someone else the floor, or allow someone else to communicate with me in their way, their own, you know, way? And again, I think this conversation goes beyond, again, language, race or ethnicity, disability status. I think it goes beyond that, because I can even think of local examples of, like, even just trying to communicate with my 2.5-year-old. You know, obviously she cannot communicate with me the way we're communicating right now. Even she can't communicate with, you know, Rosemary's, uh, uh, technology that she's using, because she's 2.5. You know, like, she's just, you know, mentally, she's just not there yet. So I even have to think about the day-to-day in terms of how I communicate with her and what she's trying to tell me, because she cannot communicate for herself. So it even starts, you know, just with communication with our basic loved ones in our lives. I think we have to think about, not necessarily, you know, thinking of everyone as a 2.5-year-old, but rather thinking in terms of, you know, what have I done today to allow someone to communicate with me in the way they know best, and how have I been patient enough to actually sit and actively listen or hear this person, and take what they have said and considered it in a way that's meaningful in the work that I do, how I treat others, all types of applications in my own life, as I engage with people within my workplace and in my community, and as I build tools to do whatever. So I think it's more of a practice on our end of looking inward to say, what have I done to actively listen to this person without immediately introducing my own bias into the conversation, or without getting overly frustrated or impatient with this person simply because I am too biased to understand that they're communicating with me in the best way that they know how. I think that's incredible. Again, it just really goes back to these basic, simple things that, again, are just very hard for a lot of people to do on the day-to-day, because we are human. So I think, again, looking inward to say, how can I, before I can humanize technology, how can I humanize myself first? I think that's the fundamental question and truth here.
Well said, well said. And I just want to read a comment that Lisa Dawn Colvin made. She said, I can't help but think how much energy is needed to not only communicate, but then have to work through the medication and then have multiple backups. It's exhausting just thinking about all the extra work. Let's use AI to make people's lives easier. I so agree with you on that, Lisa. That's why I wanted to make sure that that I read that out loud. Okay, and thank you, Chavi. She has a question for us. The question, and so Rosemary, you know, if you want to type any response, please do. Rachel or Francis, I'll let y'all decide who you want to answer it. But this question stems from the article by Meredith Whitaker of the AI Now Institute at the NYU on disability bias and AI that came out in late 2019. Disabled people are a heterogeneous population. Even for folks with the same disability, differences in race, class, gender, and other identities result in significantly different lived experiences. However, AI systems can misrecognize or fail to recognize these important distinctions. How can work on AI bias attend to these interlocking marginalizations, recognizing that the intersections of race, gender, and sexual orientation and class often mediate how disability is defined and understood? What a great question. And I don't know, Rachel, if you want to take that, or Francis, but it's a really excellent point.
Absolutely. I can take a first stab at it if everyone else wouldn't mind. I think what we don't do a good enough job of, as all of us, even as smart people in this room, I don't think we do a good job at understanding or even outlining our own assumptions that we bring to every situation. First of all, if we come to a conclusion about something, what have we assumed? Let's express what we are assuming right now, as we're faced with this dilemma or this challenge or this person or regardless again of disability status. I arguably think everybody is on a disability spectrum, me especially included. We all have a level of ability or disability depending on what we have to do, or depending on what's in front of us and what's available to us. So I think, again, having all of that in mind, when someone comes to me with a problem, or when I have to address a personal problem, what am I already assuming about my situation and those within the setting of my situation? And then acknowledging my assumptions first, and then allowing others to chime in on my assumptions to say, well, hold on, you're assuming that, but that's not the case. And usually what I notice about in every conflict that, I come across or have to mediate, it's usually at least 80% of the time, the problem stems from someone having an assumption or a misguided assumption or a false assumption. And I think when we can start to do a better job at figuring that out first, including understanding what our AI models are assuming, so we understand these inherent assumptions in the algorithmic outputs, then we begin to say, oh, okay, now there goes me exposing my own biases and limitations to this scenario. And I think, if we're going to check a box, I would say, let's check a box to ask, what are we assuming first before we move forward?
I'm going to do a real quick time check to make sure that I don't knock I'm always very conscious of staying on track. So Mia, I see that I'm going to talk for about 5 more minutes. Is that good? And
yeah, just to confirm, this panel goes on until 10:25. So we have about 5 to 7 more minutes for Q&A.
Okay.
Yeah.
Very
If you
cool.
want to take some Q&A, because you've already done a lot of great questions, I'll leave it to you. But would be nice to give the next panel a couple of extra minutes just to set up.
Sounds good. So we'll take one more question, and that'll give the next panelist plenty of time. And Francis, this is your question. And there's so many beautiful comments being made to Rosemary and to the other panelists, to Rachel, to Francis in the chat window. So hopefully you are capturing this. But we put pressure on John to ask a question. He was very kind enough to ask a question. We're training AI to simplify COVID-19 information text published by every country. It requires cross-cultural, disability, gender, age, etc. participation. What are good ways to achieve that? And then he actually provides a link in case anybody wants to see what they're doing. Francis, you want to answer it, and then we will turn it over to the next panelist, the next panel.
I think what John is trying to do is absolutely kind of the model of the future, which is you take in this case, a global pandemic challenge, right? And then you design for, in this case, information gathering and some kind of interaction with that broad base in mind. And I think Rachel, I love your comment about, making sure you know what your assumption is and don't let that kind of a change, because that will determine your outcome. I think in the business world, a lot of times, we talk about return on investment, and many times people in the investment world do not understand how big the people with disability market segment really is. And Deborah, you and I have many conversations that if you think about disability and think about aging, it's all of us. I always say it's not about them, it's about all of us. So when you go to, like, let's say a venture capitalism, when you present, it really, the entire universe is your addressable market space. But historically, I think we as a constituents, people with disability, tend to talk about the narrative from their individual segment, like I'm blind and low vision, I'm deaf and whatever. I think if we start changing the narratives to combine all the ability-based, solution opportunities, and then present it to policymakers, to the government agencies, or to the universities, then I think we will get the enthusiasm of participation, and that, our project, like what John is doing, is a very good exercise to see whether we collectively can change the perception and the assumption about how big this constituency is and what kind of impact, the government or private sector can bring to. So I think it's more than just what we do, but I always say it's not what you want to see, it's what other people want to see you, right? The perception is the reality. So I think there's some work needs to be done collectively. And I know Rue Global, you guys actually are leading some of these, changing the narratives, changing the perception, changing the assumption about what we're dealing with. So it's going to take all these factors coming together. But I believe that the time is with us, or that because it's just going to be, because the aging population is coming on.
Yeah, well said. And I would translate that to be, we are stronger together, which is what this whole conference is about. So Frances, thank you. Thank you for your brilliance. Rachel, thank you for everything you're doing, and good luck with that 2.5-year-old and your 3 grandkids, Frances, almost 3 grandbabies. And Rosemary, we all appreciate you so much. You are just breaking down barriers and shattering the barriers. And I just appreciate you and your beautiful earrings. So let me turn it over back to Mia, and let's get the next panel on here. Congratulations, ladies.
Thank you so much, Deb, and everyone else.
Thank you all so much. This was such a fantastic panel. It completely changed how I think about accessibility, expanded the definition, and just the depth of expertise that you all brought to the table was incredible. So Deborah, again, thank you so much for making it happen. And a big, my heartfelt thank you to all the panelists who took the time today to come talk to us. So that said, I would like to now switch gears and just give an opportunity to our other panelists to set up. So I'll just give me 1 second. I will introduce our other panel that's coming up. Bear with me for a second. For those of you who are just joining, the agenda is up on the screen. We just concluded the panel discussion on how to build inclusive AI for healthcare with our fantastic panel. And now at 10:25, in about a few minutes, we'll be starting with the fireside chat hosted by Chavi Chauhan. And we have Wendy Chisholm from, I hope I said that right, who will be joining us from Microsoft for a fireside chat on AI and mental health. So as our panelists are getting set up, please grab some water, do some stretches if you're able to, and just take a break, because we do have a packed agenda and we will be going on until noon. Pacific time. So with that said, all right. Hi, Wendy, welcome. Good to see you.
Howdy, good to see you. I believe I'm all here.
Great, and your voice is coming through beautifully. Let me just make a few changes. Chavi, I will hand it to you. I'm just giving folks about just a couple of minutes because it's a packed agenda and we will be together for 3 hours. So I just want to make sure everybody's staying hydrated and stretched. But we'll just start in a minute. Is that okay with you, Chavi, Wendy?
Sounds wonderful. This is all about, our mental and physical well-being. So go for it.
Stretch.
That was a terrific session, though. I'm in awe. Amazing.
I feel like what she said about, and literally it reflected everything we stand for, is inclusion of lived experiences, inclusion of women as experts, not treating them as an afterthought. And I think someone mentioned about how we see in capitalism, how it tends to only favor men. So we are trying to change that dynamic, and it's only possible with the amazing panel that you all have, the panelists and the speakers that you all have invited. So I'm very grateful for your leadership on this. So that said, I think folks should be back now. So Chavi, I will hand it over to you to lead this session.
Okay, thank you, Mia. For those of you who are just joining us today, just now, hello and welcome to this fireside chat on AI and mental health. I'm Chavi Chauhan, Director of Scientific Outreach at the American Society for Investigative Pathology, and I'm also a proud leader of the Women in AI Ethics Collective. With me today, I have Wendy Chisom, who has been on a mission to make the world more equitable. She's an author, a contributor in the W3C's Web Content Accessibility Guidelines, and believe it or not, she has appeared as Wonder Woman in a webcomic with other HTML5 super friends. So we have a Shiro with us. Welcome, Wendy.
Thank you.
In her current role as Principal Accessibility Strategist at Microsoft, she manages the selection, excuse me, and funding of projects for Microsoft's AI for Accessibility program, which is a $25 million grant program to accelerate AI innovations that are developed with or by people with disability. So just to put some context here, and we talked about the lived experiences in the last panel, right? When we talk about healthcare, we are talking about our lived experiences with regards to our health and physical and mental well-being. And none of us has been immune to the happenings in the last year or so. You know, a pandemic which has completely upended our approach as social animals. Every single individual has experienced deep mental, physical, or emotional trauma in ways unimaginable to humankind. The pandemic shined new light on existing socioeconomic inequities that have been plaguing our society forever, right? In the last several months, we have witnessed racial violence that has shaken us all as individuals. So I would just like to begin this fireside conversation, like candid conversation, just to check in with everyone. You know, this is a safe space. It is an inclusive space. So I encourage all the attendees to share their current status in light of the past 1 year or the recent happenings, if they feel up to it. As for me, I reside in North Carolina. I'm a woman, as Deborah had mentioned, the part of the largest minority. I'm a woman of color, a professional Asian woman, working woman with a toddler. Despite a supportive spouse, the beginning of the pandemic brought about huge challenges for me, which gripped me and traumatized me for the majority of 2020. I'm just beginning to start creating the space for my mental and physical well-being, and trust me, it is needed. And it is helping me get over the scars that 2020 and the recent racial violence in 2021 have deeply inflicted on my mind and soul. So while we're waiting for the attendees to share their lived experiences, let me just ask you, Wendy, how are you today?
Thank you, Chavi. Thank you for sharing. I think that's one side effect of the pandemic that I hope remains with us, is that connection and that opportunity or that awareness of checking in with each other. So thank you for sharing and thank you for asking. Today I'm doing okay. I live with PTSD, and so I woke up early this morning to go through my routine. I meditated and journaled, and I was feeling anxious about this session, but now that we're here and after that great discussion, I really feel more present and able to really participate in this. And I'm really excited to talk about this too. This is an area that I'm passionate about because of my own lived experience, but also because of the opportunity that technology has to help. And it's an important conversation because of the potential it also has to harm. And so, yeah, let's check in. How are people feeling today? I know there's a lot going on in the news. I know for myself, I needed to kind of limit my exposure this morning so that I could be present. But yeah.
Yeah, it looks like people are still starting to engage in the chat. And I do want to ask you a question. I want to like begin from the beginning, right? This is our conversation about AI and mental health. So why should AI be used to address mental health issues? What do you think?
I think it's a really good question. I think that is the fundamental question. You know, I think there are places where it could be used, and I think there are places where it absolutely should not be used related to mental health. I think one opportunity that we have, and I think especially we've seen from the last year, is that there are not enough mental health care professionals. And first and foremost, there need to be more. I really am not at all advocating that technology replace mental health people or mental health professionals, not at all. I think especially with the last conversation, you know, how do we really empower people? That being said, the lack of mental health care professionals in some regions of the world is alarming. I think when you look at the global south, some of the countries there, you may only have one mental health care professional per 100,000 people.
Wow.
So in that case, how can we help support each other? And I think, you know, we heard a lot about empathy in the last session, and I think not everyone understands how to do empathy well. I know I'm still learning. I think we're all learning. But that is one example that has been really interesting. That's one of our projects we've funded. They're actually helping people in online chat. It's kind of like a grammar checker, but for empathy. And so it can give you hints or tips or tricks on how your responses can be more empathetic so you can help support each other. And, you know, a lot of times that can really help connection, especially in this time of COVID. I mean, we've heard so much about isolation and, you know, that can really impact your mental health. So connecting with others in an empathetic way. So I think there's some things that technology can do really well. We heard a lot about in the last session, and I think there's some things that we need to be really careful about in terms of AI. But you know, where it can help empower people to make better decisions. So I don't want this to rewrite my responses for me, but where can it coach me? Where, just like a grammar checker, you know, it's just kind of there helping you and helping you evolve your responses and connections with others.
Very well said, Wendy. And I think a lot of people agree on this point, like the session pointed out earlier. And as you mentioned, empathy is, you know, the key to us being more inclusive, understanding the needs and demands of others, to be able to serve them better. And it becomes very important in the context of healthcare. And we got a lot of responses here from our attendees today. They are definitely in support of what we have said so far. It's good to see that people are happy and excited about the conference. So thank you for that. People are feeling hopeful, which is wonderful. And with the vaccine now being administered, I hope, you know, things are only gonna get better. It's good to see somebody's excited, energized, but also concerned about the state of the world. And there's every reason to be concerned where there is so much misinformation and perpetuation of hatred and you know, systemic biases. People are grateful for the conversation on diversity, which is the focus of today's talk, because that is what will enable inclusive AI in healthcare. They're grateful and they share our experiences. They're exhausted but hopeful. And they agree with you, Wendy, that we need more mental health professionals, especially in the light of the current pandemic. We need a lot more, and not just healthcare professionals, empathetic and healthcare professionals who are active listeners, as was, you know, mentioned by Rosemary earlier. Empathy is more than feeling. This is certainly a practice and skill. So they agree with you. And Wendy can talk a little bit more about some AI in the making that can actually help you, like she mentioned as the grammar checker, help you be a little bit more empathetic in your responses to whoever you're responding using that app. We do have only 25 minutes, so I want to use it very judiciously. This is just the beginning of the conversation. We'll keep the conversation going, but please feel free to send your questions through the chat or Q&A so we can focus on them. In the meantime, I want to ask you a little bit about your current role. And in the context of what you're doing, for the success of any and every AI-based project, it is critical that the model is inclusive, it's ethically built and trained, and you scope out the AI projects at Microsoft. So what are some of the key considerations to ensure that the selected and the funded projects are both ethical and inclusive?
Yeah, well, and to clarify, I only scope those for the AI for Accessibility grant program. There's a lot of other AI, obviously, in the works. And one of the things I've been doing over the last year, I mean, and this is, I've grown a lot in the last 3 years in terms of understanding what it takes to build equitable and ethical AI. I'm still learning. The technology is still changing. And I think what is interesting is that it all goes back to the initial concept and ensuring that that concept is really designed with the communities who will be impacted the most by it. And so I think one of the aspects of my job is to do a lot of educating of people, because I see a lot of trends. One of the trends is that we see engineers who have very good intentions, but haven't really connected with the community of people that they want to help. And so then we end up with things like sign language gloves. And the reason that sign language gloves are not a great concept is because sign language is so much more than what your hands are doing. Sign language is, there are multiple sign languages, just as there are multiple spoken languages. And that those languages involve your face, your body, your hands. There's a lot to it. So that's one aspect that I see. The other is that, you know, we heard a lot in the last session about the data, and that the data can help perpetuate bias and biases, and that the models and the data that you do have, even if it is inclusive, can, you know, by looking at the norms, you can actually erase a lot of the data related to people with disabilities or other minorities. The other issue that we've seen, though, is that before all of that, especially when you look at mental health, many theories, many diagnoses of mental health are actually based on studying white men primarily. And so Rachel talked some about, or someone in the last session, sorry, talked about misdiagnoses. And that's incredibly common. And so we don't want to take those data sets and build AI, because that's definitely a way to perpetuate the biases. And so there's a fundamental problem with mental health to ensure that we get equitable outcomes. And that's ensuring that the science that we're building it on is actually equitable. And a lot of it is not right now. So we had a workshop last October specifically to focus on societal bias, mental health, and Black communities. And we were focusing specifically there because as we were looking at data sets, the representation and the diversity was so out of whack that we wanted to learn more. And we recognized also that in my own personal anti-racist journey to dig deeper And so I was thankful that we could bring together an amazing group of people for 2 days. And I'll kind of preview that the paper and all the videos are forthcoming. We're working to make sure that we represented the richness of the discussion that we had. But I learned a ton. A lot of us, we all learned a bunch. And I think, you know, as we've seen recently, mental health, COVID, I mean, we're all being impacted by it. And so, I don't know, there's just a lot to learn. But I also don't want to forget that one of the main things I learned in the last year is to ask 3 questions.
What are those?
Yeah, every project that I'm looking at, this is based on the design justice principles. Who benefits from a model? Who is potentially harmed by the model? And who participates in building it? Because that really takes that nothing about us without us and amplifies that. And so really ensuring if we're building something with mental health, about mental health, we are absolutely working with people with lived mental health experience to ensure that this is a good idea. So we don't get sign language gloves, get the mental health of sign language gloves. So.
Yep. Very valid points about how to scope out, and I'm getting some response, and we have a very engaged audience. I already have some questions here in the chat, but in response to what you just said, right? Who is gonna be benefiting, right? Who does it harm? Who participates? The people who actually matter, right? Just to take it just a notch further, how is the benefit further expanded, or how do you envision expanding it going, you know, in the future? How is the harm mitigated? And how do you ensure inclusive participation? You did mention about the sign language club, or bringing in folks with a specific disability to create and generate data from that data set, right? So it's rich and usable. Could you expand just a little bit more on that?
Well, sure, which I think one of the things that we learned from that workshop too is how important not only bringing in people with lived experience, but also ensuring you have transdisciplinary teams as well as diverse teams, right? I think one thing I've seen in my career, and so I've been working in web accessibility, or as you know, making the word equitable since '95,
right,
is that, you know, really understanding people's experiences is where you get innovation. And I think what's so exciting for me is I've focused most of my career on ensuring that we're innovating for people with disabilities. And now I'm seeing the richness of innovating for even more diversity, right? And I think really reaching out and listening. I mean, we heard so much in the previous session about how important it is to listen to perspectives that are different from your own. But what's exciting about that is when you mix these different perspectives, that's where that really juicy innovation and the new ideas happen. So when we're looking at mental health, you know, I've heard clearly from our participants that you're talking with, like, transdisciplinary was the key, was the word that kept coming up, because you're talking with social workers, psychologists. You need the clinical perspective as well as the systemic perspective, because there are so many things that impact our mental health in this society. And so really trying to understand what are all those determinants of health. It takes a lot of perspectives to understand that. And we all have such different perspectives. I think the difficulty, and I don't have the answer here, I'm still trying to learn, is, you know, I mean, I think you also have to understand that you're never going to be perfect, but, and, you know, there's a certain amount of progress, not perfection, just to keep moving and learning. But having enough perspectives so that as you go out with something new, you aren't creating harm. There's a really, really fine line that I think is so important for us to figure out. So I know even in the process I use for looking at grants and who to potentially fund, I invite, 10 to 15 people into pitch meetings with me so that I can really get a diversity of voices and feedback.
Yeah, diversity is certainly the key. We do have a question from Mansi Verma. It's a loaded question. How do you address mental health with the diversity in gender, immigration status, and cultural lens in AI?
Yeah, I think this is one of the most exciting aspects of AI. I think a lot of people think about AI in terms of we're going to get a really big data set, we're going to find the trends, and we're going to apply that to everybody. In fact, personalization is, I think, really the most exciting aspect of it. So, for example, my own personal data set would include all of the apps that I use, as well as, my mental health apps like Headspace and Fabulous, but also my Fitbit, my calendar, my emails. I don't want to share that data with anybody else. Those should be my personal insights. And so how can we really create tools for people to use this technology for self-awareness? I don't want to replace my meditation. That is one really critical aspect of my mental health, is being in tune with my body. But where can I get these reminders and this help? Because that data is so useful to me. And that's one thing, one of my colleagues, Ehi Nasakare, that's some of the work that she started to do at MIT, was they looked at large data sets and some of the trends to predict mood, but that accuracy in the models was pretty low. When they added in personalization, not only did their accuracy get better, but I think that that's just, we're all so different. I think that we absolutely have to, I think that's absolutely where we need to be heading, is to figure that out. And I think that's also the work that Yuta Treviranus and staff at OCAD are doing is really great, because that's also, how do people own their own data? And, so.
Yeah, a lot of people are commenting on personalized medicine, which seems to be, the thing, or the new emerging, fad, I want to say, because of whatever experiences I've had with it from the research perspective. But you did talk about interdisciplinary collaboration. And I know in her opening remarks, Mia mentioned about a community helping her to bring this, whole Women in AI Ethics Collective into being. So since we're limited for time, to me, interdisciplinary collaboration is must when it comes to, training AI, like AI scientists, the healthcare researchers, the clinicians, the community, and of course the patients and the caregivers, to build any strategy that is going to be inclusive, that's going to be ethically developed and deployed, right? And you guys are doing workshops to get those voices heard, to get those perspectives in. But I'm certain that these collaborations come with their own set of challenges. So in your experience, what has worked and what needs to change when it comes to these interdisciplinary collaborations?
Well, yes. So the more perspectives you have, the harder it is to sometimes get to consensus. And so, how do you do that? That's kind of the challenge. But it's also, like I said, where the richness comes from. One project that I'm really excited about, we've funded, that isn't specific to mental health, but is related to cities and transportation, is really working with cities to help own data around sidewalks, and finding a gap where right now, so, and just because this is AI, and getting out and walking can also be good, and I think there's a lot of opportunities there. Any of the routing that we do as pedestrians, those routes are based on roads, and that's because sidewalks themselves are not first-class citizens in the data sets. And so that's another thing that we're funding to do. But getting that data consistent and getting people to own that data is really part of the issue. And so what I think is difficult is, how do you you need to build a big enough table to get people seated around it. And sometimes you need to build multiple tables, and then they all need to kind of move around so that you're getting the ideas flowing. But really, yeah, getting voices heard. I think that is the most difficult thing. And I know one thing that we're practicing a lot of is just taking that time to go around the room and call on everybody.
Yeah, I see Mia up here. Are we almost on time, Mia? Wendy, it's always a pleasure talking to you.
Wrap it up. So no, we have another minute if you want to wrap it up.
Okay, I just wanted to thank Wendy. You know, it's always a pleasure to talk to her. And I want to tell all the attendees that this is not the end of the conversation. This is the beginning of the conversation. And we have to bring in collective efforts and different perspectives to make things change in the healthcare ecosystem. You know how to reach us. So please do. And let's keep this conversation going. Thank you.
Yeah, thank you so much for having me, and thank you for the great conversation, and nice to meet you.
My pleasure.
Likewise. Thank you, Chavi, for hosting. Thank you, Wendy, for taking the time. It was a fantastic conversation. And to Chavi's point, this is only the beginning. And we look forward to seeing you back again, Wendy, as well as all of you other attendees. So that said, let me just share with you what's coming up next. Someone had a great question about different types of diversity. So I'm very excited to share this next panel with you all. And this is Ethical AI in Healthcare Perspectives from East and West. This is hosted by Ayushi Tandon, who has brought together a fantastic multidisciplinary, geographical perspectives into our event today. We do believe that it's important not just to look to experts who have done research, but also look to experts with lived experiences, and not just somebody sitting in the Western world telling you what is, giving their perspective on the Eastern world. We really need people from those communities. We need especially women in those communities to come join us and speak to these issues. So I'm very excited. This is a great panel put together by Ayushi. Just in terms of timing, we do have an hour for this session, and I will hand it over to you, Ayushi, to lead this conversation. And quick reminder, please stretch, get some water in case I didn't mention it in the last hour or so, but do take care of yourselves.
Thank you, Mia, and thanks everyone for joining in. Let me start by saying namaste, namaskaram, aloha, kimonashan, vanakkam, and assalamu alaikum. So this represents the diversity which we have in this panel for you all. These are just the greetings, and this is very small sense of the glimpse of the diversity which we have in this panel. I am Ayushi, and first I would like to thank my panelists who are joining in the difficult time zones. Some are staying awake and some are there to share their thoughts with you. So thank you so much. To tell a brief about myself, I've done my PhD in women health and women health records, and soon I'll be joining as an assistant professor in a university in India. Thank you, Jeff. And all the panelists we have here are actually my mentors. So I'm really excited and thank Mia and Lighthouse3 and Chavi for helping me arrange this panel and bringing all my mentors together on this forum to share their insights with us. So let me first introduce the panelists. We have Dr. Nemi Rangaswamy. She's an associate professor in Kohli Center on Intelligence System at Indian Institute of Information Technology, IIIT Hyderabad. She brings an anthropological lens in understanding the impact of AI research in praxis. Among many work, her recent research on exclusion or inclusion in the digital identity and field trip as a method for generating insight are very relevant for this panel. Then we have Dr. Nova Ahmed, who is having an inspiring journey of getting PhD and training in the Western world, and then coming back to her country of origin, Bangladesh, to pursue teaching and research. Some of her work relevant for this panel and discussion are on wearable devices, use of technology like mobile by women, and meaning of privacy among women living in the patriarchal society. Aloha, Dr. Jennifer. Dr. Jennifer is an Aloha spirited researcher and professor of communication at University of Hawaii, Manoa. She has been working on patient-centered or patient-generated data, health data, and its relevance and contextual integrity of the big data. She's worked a lot on health data and big data policies. So with a small introduction of panelists, I welcome you all. And all of the three panelists we are here talk a lot about women-centric, patient-centric, human-centric AI in multiple ways. So that's the first thing which I want to understand from the panelists here. What is this centering for you all? And would you like to give some example of technology, AI technologies in the health system, which according to you are actually centering the patient and particularly the women, particularly in the context of countries where you all are working and your research is based? We can start with Dr. Jennifer.
Thank you so much, Ayushi, and I'm so pleased to be here at this event today. If I understand correctly, you were asking about, in particular, what I'm looking forward to in terms of AI technologies. One thing that was already mentioned a little bit earlier in Wendy's conversation and some of the panelists was the precision medicine. It enables, obviously, diagnosis and intervention of disease progression by analyzing large multidimensional data sets of genetic data. Linked to that, of course, is the idea of AI-enabled drug discovery that could be personalized for individuals or communities. I will say, though, that I am, as I'll get to later, hopefully, in the discussion, I'm still concerned that this won't be available to all of us.
Thank you, Dr. Jennifer. Dr. Nova, would you like to add something on that? What is the technology? What is the key technology of AI which we're aspiring and looking at in healthcare?
In Bangladesh, it feels bad to say that, but I mean, we still need policies to in place. For example, the very first research paper that was published right after COVID, when COVID was, the first patient was found in Bangladesh around March last year. There was a paper based on predicting model. So what would be the probable number of deaths, number of infected people? And right after that, there were some government push, and the universities publicly posted that this research is done by them on themselves. Universities are not attached to that research. So that's a big concern when we are dealing with artificial intelligence predicting model, where also the researcher safety. At the same time, I'm a little bit concerned about the privacy of people, because when we talk about, often we exclude the illiterate or poorly literate people, and when we do include them, we do not, the record keeping and everything is just open often if it's not done right. So that's the concern. But the positive part is that we can do a lot without, if we have a good representation. So it's a time we have to step cautiously and not make the mistakes that are already done out there. So we are in a better place with better example. Thank you.
Dr. Nimi, I think you would also agree with the illiteracy part in the context of India. How would you see AI in healthcare, and what are the technologies in your view, in your research experience?
Yeah, sure. Thank you, Ayushi, and thank you for really inviting me. This is HCI across borders in the true sense, and I'm happy to be a part of this, and I really enjoyed the sessions up until now. So to answer your question, I'm an anthropologist. I'm not an AI expert or a data scientist, but I work among data scientists and AI practitioners and theoreticians. So in that sense, I have an immersive kind of understanding of what's happening in this area. But coming back to India, I do agree with Noah, and I'll be coming back to those issues. You know, it's not about just the diversity in India, it's also about the various kinds of disabilities, that there is a diversity of disabilities in India. Even if you take gender, the spectrum of people who experience gender biases or even gender discrimination is so huge. You know, diversity is the key word. I'll come to that, the challenges of being a diverse country, which in itself, it's not a, see, diversity can be celebrated, it can be a word that denotes something positive, but when you're finding solutions, when you're building technologies, diversity is not necessarily something that is helping you, right? But having said that, going back to the technology question you asked, this is something that's one of my favorite technology kind of, what do you say, technology that has come out of India. And we all know that India is a startup heaven. Entrepreneurship in technology is something that is celebrated. So this was, there is a very interesting startup called Niramai. It means freedom from illness. That it's a Sanskrit word, I think. This is started by my ex-colleague. We were colleagues when we were in Xerox Research India. Niramai is a homegrown technology. It uses machine intelligence and artificial intelligence to understand and to detect early breast cancer. So they essentially use thermal images and use a diagnostic engine to detect early breast cancer. And this is probably one of a kind in India, where a software and a cutting-edge AI engine is used to help this specific health hazard. You know, I mean, it said that every 12th woman runs a risk of getting breast cancer. So this is what this brings to me is it's not only cutting edge, it's also about, it's also specific to gender. It's also about inclusion, and it also doesn't discriminate the kinds of women which this technology is available to. So I think I'll go with that. It's on a bit of a celebratory note, you know, a little bit of a difference from what Nova said, but I'll come back to Nova's focus later on when I talk. Yeah. I can't hear. I can't hear you. I can't hear you, Aisha. Yeah, Aisha, I can't hear you. Yeah.
Ayushi, we're not able to hear you. Do you want to just, okay. Do you want to add your questions to the chat if you're still there? Maybe it's just an audio issue. Okay, it might be just, let's give her a couple of minutes to get back on. So Dr. Nova or Jennifer, or would either of you like to chime in on what Dr. Nime just shared with us?
Yeah. Am I audible now?
Oh, yes, you are.
Yes. Okay. Yeah. So I was actually asking Dr. Jennifer, would you like to add something based on your experience in Hawaii and the ethnical diversity and other aspects in the history of Hawaii, what you have experienced and how some technologies would succeed in the context of Hawaii, which is different from mainland US, and some things might fail?
Yeah, I think, well, one major thing that we have is huge health disparities that are very well documented and truthfully not well addressed in the area of Pacific Islander health, in particular Native Hawaiians. And so I don't know of any particular technology thing yet there where there's the huge disparity, but in terms of looking towards the future of AI, I can see that even just given this last year, what we've discovered is that many Pacific Islanders, they're much more likely to get COVID and to suffer the ill effects of COVID. Deaths have been disproportionate towards those communities. So as we move forward with AI, I don't have the confidence right now that somehow that's going to magically bridge that gap. And so I think we need to do a lot more now, as others have mentioned in previous panels, to start addressing that disparity moving forward. We also had a very interesting case with a major blood thinner recently, where I believe it was just in the last month, a judge basically gave over $800 million settlement to people in Hawaii of Asian and Pacific Islander ancestry, because it turned out that there had been a false and deceptive practice where they were advertising this as something that would work. And it turned out that many studies, genetic studies, indicated that it wouldn't. So again, that's not particularly AI, but just moving towards the future. I think we see those trends. We need to change them in order for people to have the full benefit in Hawaii.
Yeah, so if I may hear you right, we can say that for whom technologies are designed. So we really need to question for whom we are designing these technologies. And this is an important debate in the technology design. And to bring it in the context of the AI, for whose benefit we are thinking about, and who are most likely to derive benefits when you're talking about AI and ML in the healthcare. So one way is to say whose benefit, another way, which the way I would like to ask is who are getting excluded when we are talking about the AI and healthcare debate. And Dr. Nova, I would like to start with you on this question, and then we'll go to the other panelists.
Thank you. I'm already feeling sorry for starting with a negative tone, but I mean, but actually, technology offers a lot of hope, especially the countries that are left behind. But during COVID, I got a chance to talk to many people. We were actually conducting a study for women who are working with garment industry in Bangladesh. And when the COVID-related lockdown happened, we were actually finishing up our studies. So many of them reached out to us. What should we do? Where should we go? Where do we get all the information? And it was surprising to see these people, the garment workers, are not actually the very poor people. They are earning money. They have their own phones, but they just work so long that they don't have the technology literacy. You know, I mean, they don't get to play with their mobile phones. So their children get to learn to use internet. And I mean, they get some entertainment, but getting information or useful information, because there were lots of information being disseminated. But I mean, that's how you get excluded from a big portion of data. And again, from the data collection perspective, I mean, because these people are always busy, they're working. When we are thinking about people, we often miss the voices of them. So that's something, I mean, I think it's something it will not come naturally. We just have to push ourselves to have that representation, to have those questions or to have those concerns. And now it's a very good time to see where we are standing. What are the gaps? Where can we put good, I mean, where can we ask the voices to fill in, and how to make the policy that is friendly enough, that is open enough. And another thing that came from Jennifer's concern about the misrepresentation of blood, I think as we are moving forward, we have to be extremely careful to make it transparent, because until we have the transparency, there is always that mistake that we will be doing the mistake that has been done before. And for people like us, we cannot afford to be in this position. It's a vulnerable population. And once, I mean, it's very black and white. If something bad happens, they will say, okay, AI is bad or AI is good. It's always AI is like a God syndrome type of thing, or it's solving everything, or it's the evil thing, it's just ruining everything. So we have to be very careful in these places. That's what I think. Thank you.
Yeah, and just to add to this, maybe we should also think about the religious diversity which we are having in these countries, and also the cultural diversity, the patriarchal norms which are operating in our country, which define many a times a patient not as an individual entity, but a patient living with a caregiver, and also many a times women having subordinate position in their families and society. So Dr. Nimi, if I go from here to you, how would you define whose needs should be considered?
Yeah. Yes. Before coming to that, I really loved the point Nova was making about how we project these technologies. The beginning of COVID in India is about, say, 10 months ago. Now we are 1 year into the COVID scenario. It was given a very communal tinge. Certain sections of people belonging to a certain religious, who are practicing certain religious faith, were attributed with the COVID transmissions. So it is when literacy is again, there is a spectrum of literacy existing in a country. All these grays get submerged. It's either black or white. It's either right or wrong. So the way you project technologies become very important in their adoption and ultimately the impact or implications they have. That I think that's a great point. Now, I just want to draw your attention to another huge project in India, which is the Aadhaar Project. It's giving a unique identity, a digital identity to every citizen, to 1.3 or whatever, 3+ billion citizens in India. We have, I think, about 1 billion Aadhaar identities today, but the long tail, the 300 million that are left out, it's so difficult trying to give them an identity because they are homeless, they don't have address, there's no literacy, probably they don't have a stable occupation, they don't have any records of any sort, including birth certificates. Now, we transpose the same scenario onto the same bunch of people who might be potential beneficiaries of cutting-edge healthcare through AI technologies. We are going to run into the same problem. How are you going to include people who are invisible? Right? They are rendered invisible not just because of literacies or certain patriarchal or misogynist kind of culture that is prevalent. Because they don't have records, they are formally invisible. Now, what do you do to such people? How would you include them? How would you bring them into records? AI technologies are all about data that can be digitized. How do you digitize people who don't exist on paper or something that can be digitized? So this is a problem that we are going to bump up again and again in India. And I think the Aadhaar project brings this out very, very forcefully. And any other technology that is aimed at inclusion are going to run into very similar trouble. The long tail, especially the long tail which runs into millions in India, who are invisible because they cannot be digitized. I think that is something we have to think about.
Yeah, a very valid point, Dr. Nimi. And since in India, the conversations are going about linking Aadhaar, a digital identity, with the unique health ID also, that makes this question of invisible population very relevant. Dr. Jennifer, how do you think about the people whose needs we should be considering in terms of AI healthcare?
Well, I like that you're asking about who should the beneficiaries be, but let me start first by saying who the current beneficiaries probably are. And that would be big tech investors, those wealthy enough or privileged enough to be able to afford healthcare services at all, and products that are going to be enabled by these AI applications. So I remember a news story from a couple of years ago where a commonly used algorithm that was used by hospitals was revealed, it was used to forecast which patients would likely need follow-up care. And it was determined that it was classifying white patients as needing additional care at the exclusion of Black patients. That's just one example existing of where we see a major gap. This idea of invisible populations that Nimi mentions is also really powerful, and I think one that we need to engage more in our discussion. And I've already mentioned in the state of Hawaii what happened with our Asian and Pacific Islander population paying for a drug and taking a drug expecting health benefits without. So really, I think the answer there is just very, very broad. It's basically huge numbers of people that potentially will be left out of the conversation, whose voices won't be heard and who won't see the benefits unless we are much more, I think, assertive in taking action today.
Dr. Nimi, there was a question for you, and I'd really like you to comment on it. Since you have only brought this topic of invisible population, how would you think about including this invisible population and gathering them
Yeah.
into the data which is used for training algorithms. This is by
Yeah.
Chavi.
Yeah, thank you, Chavi. Again, I'll go back to Aadhaar. Somehow, the people who are driving Aadhaar are people, I think, who have their hearts and minds and everything into it. So they have done a few workarounds to get the invisible and make them visible in the system. You know, the way you capture somebody digitally in this in the Aadhaar is, you use the iris, you use the entire thumbs, and then you use face recognition, stuff like that. So people, especially daily laborers, most of their thumbprints had got erased, right? So they would use face, for example. So they had different ways of capturing digitally people with problems. And if people didn't have an address, they had a text box where they would fill something, maybe an approximate address. If people did not have a birth certificate, never mind. So they were getting around a lot of things, understanding the fact that there were millions and millions of people with no records. Now, so this was a workaround technologically and sociologically, in the sense, in the field, when you're out in the field, getting people to enroll into the system, you do it, you have something like the point of sale, right? So at the point of enumeration, you're making these workarounds. So I would kind of take inspiration from that and suggest that, of course, you're dealing with cutting edge AI technologies, healthcare and all, but at that point of contact between, say, the health worker, technology, and the patient, I think you'll have to really tease out creative solutions to be able to get these people enrolled. The first thing to do is make them visible, right? As I said before. So try all these. Technology can come to your help. You can try an array of technologies that can be suited to a situation where records don't exist, or do things, make technology versatile enough to include people who are beyond digitization, like what Aadhaar did, you know. So this is where I think you need a different kind of zeal. It's not enough to be a technocrat or a techie or this cutting edge thinker. You have to extend that technology to non-technological areas to bring and enlist people in, you know. So that, I think, would be an interesting way of thinking about this.
Thank you, Dr. Nui. But when you're telling this, I was actually thinking about the discussion which Dr. Chavi and Dr. Wendy were having. So Dr. Wendy had talked about in the previous panel about the design justice and applicability of design justice principle. Maybe these are the languages which we can also adopt in designing the technologies. And design justice principles should come from the context of the country or the place or the people for whom we are operating and thinking about technologies. So the next question is that how should we be designing and who should be included in the design of technologies? And what should be the process around the data generation, data gathering, testing of the technologies? Dr. Nova, based on your experience, how would you comment on that?
I think we have to look at how we handle things now, because when we come to technology, with my experience, it has a lot to do with trust. So whenever we see a portion is excluded, often it's not because lack of technology is there. Often it is with the technology, I trust it to be good enough. I trust it to help me. For example, with financial inclusion, all these mobile phones, and during COVID, we wanted to see how it's helping people out. And we see that there are lots of many points of fear in the technology use, especially with women, especially with underrepresented people. So we have to put the best picture out there. I think that's a big portion out there. And also I have seen people who are not technology savvy, who are poor, and they don't have access to many other resources, have kind of, that's amazing to see how they survived. I have seen great community support. Especially in rural areas, nobody will eat not knowing about what happened to the neighbors. And this is nothing, it's nothing like what we experience in the city. It was COVID and it hit hard on people because there were many of the small businesses, many of the small informal works were stopped entirely. But we see how strong the communities can be. And I think when we design, when we think about the users we are losing, we have to think about the strength we have. We have to think about the strength of the communities, the trust of the communities, and think about the beautiful aspects that are already out there, like co-designing, or sitting with them, asking their suggestions, because people are so humbled. When we ask them for their suggestions, when we ask for their opinion, they actually open up. They will tell you stories that they will keep repeating, they will keep telling you. And I think there is a lot to do. We are standing in a place where technology has lots of opportunity. We just have to open it up. So I want to end this with one story. When we met a garment worker, I'm telling it to a lot of people. So we went to a garment worker's house where the dad and mom both are garment workers. And the father actually, when he saw us, and my students were all computer science students. So when he came to know about that at the end, he brought a picture of his daughter. He said, "This is my daughter. And the night she was born, I went out and bought a computer for her, because I want her to be a computer engineer. I don't want her to be a worker like us." So I think, technology has that hope for many, but we just have to hook it up to the right place so that it does not, it does not ruin that hope. Thank you.
Yeah, and I think similar kind of trust we see among doctors and other healthcare workers in the community, particularly in the India and the West Bengal, where frontline workers are going door to door in the time of the COVID also, and in the earlier times also. And the key aspect which works is human to human trust in the healthcare system. And
Yes, like the previous speaker was telling us, like bringing the human in on board before we think about the technology. I love that word a lot. Yes.
Yeah.
Sorry,
So,
Ayushi, I think I
no,
stole your words.
definitely. You actually paraphrase it much better. So these are the things in terms of design justice principles, which even I would like to add, as we can think about the community values, empathy, which exists in the community already. Rather than defining empathy in some other terms, we can actually understand the communities and define the empathy which exists, and maybe try to train the human, with the help of the human AI systems, to be more empathetic and be more trustworthy for the people with whom we are designing these systems. Dr. Jennifer, how would you like to add on to this discussion about this? Who should be designing and how they should be designing?
Well, a lot of my research deals with the conflicting value from different perspectives in the data, but I also think the values are embedded in and shape literally every aspect of AI systems, from the data to the algorithms and to every single choice that's made about context and use in particular context. So a key question to kind of echo your earlier questions and what Wendy's earlier comments is, whose values are driving health AI innovation and use, and also the oversight of that. So I see basically as all of this is steaming ahead, there's a lot of inertia, again, that does have embedded values in it and that is excluding many others. And so I think certainly principles like inclusive design, which Rochelle mentioned earlier, human-centered design, which I think has been a theme today, interdisciplinary teams, which Xavi mentioned, all of these are super, super important. I mean, just look at what's happened, for example, at Google with the AI ethics team. It's raised so much concern in the community about how we can move forward, how we can actually have representation that will meaningfully shape the future of these technologies. And one last thing, I think integrating, I think this has also come up several times today, the aspect of privacy. So integrating things like privacy by design from the ground up into this is very important, because as we want people to be included, we also have to respect and protect their data and their right to have ownership over their data.
Dr. Nimi, since your field trip as a data collection method is very exciting to me, around that and other thoughts you have on how design of technologies, particularly AI healthcare technology, should be happening in the context.
Yeah. Though I am this field site, what do you call it, junkie, but I am also inspired by technocrats sometimes. If you want to design good AI tools, there has to be a good technocrat doing it, right? So if you are building a cutting-edge healthcare system, it has to be done by the right people. You have to have good AI scientists to architect the system. AI is a catchword, right? You can sprinkle AI in a company or in some organization or in a program and say this is AI. Right? But it is not AI, right? Just because you're selling something online, a store sells its products online, it doesn't become an internet company. Amazon is architecting its business via the internet. That is why it's an internet company. Similarly, I think to have a working technological system, you need very good technologies and scientists and engineers to do it. Now, having said that, how do we, so we get the right technology out of the way. So you have a good technology system, you have a fantastic, say, AI tool that extracts and analyzes, diagnoses data very well. Fine. So it's a great tool. Now, what is the data? Now, suppose you don't have data for 400 million Indians. Where any amount of cutting-edge diagnostic tools is not going to help these 400 million people. Now, this is where probably you have to shift gears and not think, not wear your techie hat, and probably wear your anthropological hat, and look at how are you going to bring data to technology or take technology to data, right? So now how do you design systems where there is a data drought, right? In systems like India, where India has a very poor history of archiving material. Now of course we live in big data. We live in a big data universe, but it's very poor. We don't have a good archive. We don't protect things as we should, So in a system like this, how are you going to bring data into a system? So this would be my primary question. Though we can humanize data, we have health workers, we have frontline workers, all those human beings can bring technology closer to those who are excluded, fine. But then when you're thinking AI, when you're thinking cutting-edge technology, how do you feed it with things that are excluded? I think that is where we'll have to crack it somehow. You have to reinvent the wheel. You'll have to you have to digitize, you have to datafy people, contexts, and experiences, which ultimately would result in building technologies for these people, because we are thinking through that technology lens. So we can never forget that, So I think somewhere technology, big data, invisible people, and the bridge to bring all these things together must work somehow.
Yeah, thank you, Dr. Nimi. You made very excellent point about data and data gap that exists. But something like that I often wonder is, being an engineer by my roots,
if you leave designing of AI systems on engineer Ayushi, she would be thinking about the metrics which are taught to us in the engineering courses, and largely AI ethics courses are not that popular in the global south, at least not in India. The computer science is taught as a very technology utopia driven course where the algorithm accuracy is taught to us be calculated on the basis of accuracy matrix, comparison between the pre-existing matrices, and how our algorithm or machine learning is trained better and just performing maybe mere 1% and 0.75% better than the previous algorithm. And we just published the paper out of it. And also in the healthcare, also many papers are getting published. So those are the people who are designing the systems. Those are the pro-technology people, a particular type of trained people who are working in the computer systems and algorithms, which are getting deployed in the healthcare systems also. So my next question, and I'll start with Dr. Jennifer Yu, because you work in policy and data governance. What is the matrix? What are the parameters of the matrices that we should think about when we start talking about AI systems getting deployed, getting more adopted, getting more mainstream in healthcare? How we should be measuring them for their fairness, accountability, or any other parameters that you can think of?
That's a really good question. I can't say that I know a lot about measurements. Obviously, I would turn to other people in the fairness, accountability, and transparency movement who are specifically doing that. I will say, though, that I think to address these issues, we need to take a multi-pronged approach. So there's going to be certain things like intelligent regulatory efforts to perhaps constrain data use, things like data minimization. That's also needed, however, for things like deep learning. So there's this incredible tension. Another thing, obviously, that we need to do is look at some more type of organizational things. Like, I love the idea of these AI ethics boards to come forward. So far, we've had some problems with those as well, but we need to have a lot of international and also corporate conversations there to talk about truly that. And then a third thing is that there is a role for technology here in terms of doing this. And that maybe we'll get to your question about measurement, things like the algorithmic audits and so forth that could be deployed, but we shouldn't think of those as somehow magically going to fix or make things that are already not equal more so without, again, a lot of effort. So maybe my co-panelists have some more insights about the measurements.
Yeah, Dr. Nova, what would you like to add on this?
I think these are valid points, and we have to look at the people who are working already specific to that field. Along with that, I want to ask for this option as well, to look at the qualitative aspect of the data we have, because even missing, when we are looking at AI and big data, we are often missing the corner cases, or the cases that are very few in numbers, but it needs special attention. For example, when we are dealing with our population, especially in Bangladesh, we entirely miss the elderly population. But it's not that they're not using technology, but when we are even when we are advertising technology, it's always the youth. The attention is on the young people, and it's designed for them. And just a little bit of effort could actually include them, but we don't have them often enough, and we won't have enough data if we are voluntarily asking for data. So we have to be careful and mindful about what we are missing out, so that the AI based decisions are not impacting major decisions that could hamper their benefit. For example, we can make a decision that is broad enough, but decisions based on inclusion and exclusion, that should not be based on AI if we are thinking about our countries, where we have a big diversity of people, and literacy is a big problem, and technology literacy is another problem on top of that. So yes, I think we have to, I mean, these conversations are actually the starting point. Thank you.
Thank you, Dr. Nova. And before I come to you, Dr. Nimi, we can take up the questions. So those who are attending and have questions, they can post question on the chat or on the question answer systems, and we'll pick them up as and when we get the question. Dr. Nimi, how would you define the measurement of or the evaluation of the AI algorithms in the context of the healthcare?
Yes. In fact, I think that was a very interesting point Nova just made, that we should not privilege AI and AI-driven tools as the only way to categorize and measure things. There should be other ways of doing it. I'll come to that. But I'm reminded of this fantastic book. I don't know whether I'm forgotten the right. It's called The Tyranny of Measurements, or maybe it's a tyranny of statistical significance or whatever. It is about the tyranny that the importance of measuring everything imposes on us, right? If you cannot measure something, it's out of the window, right? Something that is not measurable is also not datafiable, is also not included in something that you're building, right? So I look at all this metric, this measurement, this precision, which are keywords in AI technologies, as somewhat of a tyranny, because I'm an anthropologist, right? I'm here to muddy the waters. But then what do you do when you shift your focus from the developed global north to the developing or the difficulty in developing kinds of countries in the global south? You know, measurements also come with privilege. It's only privileged spaces that can be measured, right? Because measurements have some preconditions. Unless you meet those preconditions, you cannot be measured. Just like the countries that take off into capitalism, they have to meet some preconditions, right? So it's something similar to that. So when you arrive in a country that still exists in various states of unmeasurable states, for example, how do you bring these metrics? So this is where you know what Nova was saying. You know, we have to. There are many ways, many kinds of measurement that will have to coexist at least for some time. Probably we use some legacy ways of measuring things, which countries like India has used, right? Maybe there were ways in which we measured certain experiences qualitatively. So bring them on, bring these legacies. They can coexist with cutting edge things. It's okay. It's okay. For some time, it's going to be a bit precarious. Okay, here there is a cutting edge thing, and here there is this legacy thing that is ancient. Never mind. You know, let them coexist. Let us try to be as inclusive as possible, using different ways of measuring experiences, which ideally cannot be datafied. That seems to be my running theme today, the undatafiable. So I would argue for different kinds of measuring things. Sometimes it could be country specific. It can be a legacy system that you're calling in for. So this can be one way of surmounting the tyranny of big data metric and big data measurements, you know? Yeah.
Yeah, this is a very interesting point, and particularly this makes a space for the qualitative research which is happening in the AI algorithms, where people try to bring in the tail cases or the cases which are generally left out, and the experience of those people, and giving voice. And specifically what we have seen across the panel in the today's session, we talk about the AI systems which should be designed for giving voices and enabling the differently abled people. And another thing which came about overall in this today's conference was about the empathy towards the people. And since we have time, I would again start with Dr. Nova. How would you define the empathy in the context of your research, particularly in terms of the healthcare? And what is empathy, which researchers and designers and policymakers, anyone who is working in AI healthcare and bit disconnected from the actual population should have? What is the empathy?
I have to admit that I learned about it in the hard way. I studied in US in Georgia Tech, and I was a systems person. I did my PhD in systems, and I worked a lot with sensors and wearables. And I thought I can make anything and solve the problems. So I came back to Bangladesh, and at that time there were lots of sexual harassment cases going on, and there were several suicides of young girls, like there were class 8 and class 9 girls, one after the other, another. I mean, it was a very bad time when we came out here. And at that time, we did not have that emergency phone call system that you can call and get something. And I thought I should design a wearable, like you can ask for help. You are wearing a locket or a bracelet and you can ask immediately for it. And at that time, when I started to talk to people about making this bracelet or how it will be, I found out that many would not talk to me. Because nobody wants to share the pain. It's not a good story. If you have faced anything, how would we design it? And I had lots of posters. If you want to share anything, please come and talk to me. All those posters were torn down and people were sending me hate emails. And at some point, we thought, okay, probably this is not a good time. And at that point, many would start to call me up, meet me secretly and share the stories, because they found my genuine interest in solving the problem. And it was not only in the places I was looking for data. There would be somebody from the next door neighborhood. There was the maid who was working in my mom's place. She would come and tell me her story, and she would come and ask for a solution. And later, when I started to work for wearables for car drivers and others, I found out, like, just asking for what you want is a big deal for this population, because nobody goes and asks them for that. So when I was working with the car drivers, they will tell me, Appa, please sit down with me. Appa means sister. Sit down with me and have some food. Let me buy a cup of tea for you, just because I'm listening to his story. And I think it goes a long way from our side, from their side, and also together at the policy level as well, because it cannot be done by me or you or just by that person or together all the scientists. We need to also have those placeholders where we can fit these things in. And I definitely think empathy goes a long way, much farther than we can think of. I mean, I believe in that. Just look at today's panel. I think we just made a connection here. We can go forward with whatever energy we got here. Yeah. Okay. And I must confess, at night, because it's late, I become very agreeable. So my logic might be a little bit bad.
Thank you, Dr. Nova, for sharing your story. And every story which a researcher shares also makes researcher vulnerable. So it takes a lot of courage to share the story as a researcher, and I really appreciate that. I'll go to the questions which are there on the question answer, and I'll just put the word which I've learned from Dr. Jennifer to the empathy. So I'm taking just for you, Dr. Jennifer. It's, for me, empathy is also aloha, which is what you have taught me in the conversation, because it just means so many things: peace, mercy, compassion. It's just a word which combines everything. And that is what you have introduced to me as a researcher. And that is what I would like to share with others also, in terms of what is empathy, what can be the empathy also. So we have one question from the Susanna. I think it's for Dr. Nili. With digitalization, many illiterate people lost access to their pension and government giveaways in India. Before digitalization, they could go to an office and demand with their ration cards, paper-based card. Now they have no idea how to proceed. So with this, is it good idea to digitize without educating the population? Didn't tech expand the problem in this case? And maybe this could have the repercussions for the people in the health care also, when they are not literate and they will have everything linked to the digital identity systems.
Yeah, it's a good question, but there is, I think I would not agree about the pre-digitized life and context in India. They were terrible. They were horrific. The leaks in the public distribution system was one of the worst in the world. You know, probably about 30–40% of these what do you call subsidized resources where the system leaked them to people who would resell them or whatever. That is why digitization became very important. That is why things like Aadhaar, unique identity became important, because they felt that the leaking would stop, it can be plugged, you know. So I think there is no romantic past that that we can go back in order to talk about, to critique digitization. I think digitization should be critiqued on its own terms, and probably it may not be a good idea to look for something that was better than that. I think there were only things worse than that. So having cleared the way for some technology optimism, I think, I feel that, yes, I do agree with the person who's Suzanne, who asked the question that, yes, in a country with indefinite literacy levels, digitization closes doors. It makes a system formal when there was some human element before that. That I agree. But I think in the last few years, there has been the last mile kind of help has been extended to people. A lot of agencies, middlemen. If you take away middlemen, they'll go elsewhere, right? So there are so many middlemen who are your internet brokers who help you connect to the system. I don't know if that is essentially good or bad, but this is a response to digital illiteracy in India too. I'm not saying that is the best response, but these are some gaps that are being filled by the market, you know. What I feel is, until digitization happens, I don't know if 100% digitization is ever going to happen in India. It may take a long time. We have to allow different modes to exist. Just embrace diversity here. You're embracing diversity and celebrating it. Why do you want to totalize? Why do you want to have a totalizing vision of digitization? Embrace diversity here. Find ways by which digitization can coexist with other non-digitizable ways of including people. You know, I think that is the way to go forward in India. There will always be that 20% who will not be connected to a system because of the conditions, right? So I think we have to allow for a few things to coexist. You know, India is celebrated for coexistence, right? So why can't different modes, different conditions, which is, it could be a pre-digitization condition or whatever, all these things should learn to live together, at least for some time to come, you know?
Yeah, and I really like the point of coexistence of the technologies, like coexisting of the diversity. Dr. Jennifer, I would like you to take this question. We are talking about the technology on a track and human are working in progress. This is by Lavina. Where is the interoperability between the countries and the continent? And specifically, this is very relevant for the kind of research you're doing, because there's a mainland US, and then we have talked about the Hawaii and the patient records and the remote healthcare system when somebody moves in from the mainland to the Hawaii Islands, or go from the islands to the Hawaii. In fact, the islands in itself are very remote. So how is the interoperability between the continents would come into practice, and what would be the implications for data privacy and data sovereignty in case we start talking about data exchange and standards?
Well, let me start by saying that in the US, we have I would say almost long-suffering electronic health records system, which is, is still very, very problematic. So between continents, obviously, I think the thing for me is any type of standards development, obviously the categories that are chosen, et cetera, become very problematic. And then there's also the issues of privacy and security that you mentioned. So my short answer to that is we still have a lot of work to do in the US. My own experience of it has been, even here, I can't even get the electronic health record to show the actual doctor that I see. It's still a few years back from someone that like I met once and then abandoned their practice. So I think in terms of the privacy and security aspect, so one thing that we should think a lot more about is that, again, there's these underlying values in the data, meaning that different actors, different entities have values. And some of these are cultural values, some of these are just perspective values. And so when we're talking about standardization, data sharing, data sovereignty, and things like that, we always really do have to look at the context in some great detail, but also in the alternative potential of the data, if that makes sense. So right now, the data might be used for something like, intellectual property development for machine learning, monetization, and so forth. But we also have the possibility to use that same data for broad community-based values, including things like equity, identifying and correcting health disparities, and so forth. So I think I'm a little worried about the idea of, more standardization without fully understanding that. On the other hand, without standardization, we cannot have these large data sets. So it's sort of a difficult question. In the US, we also have something called the APCDs, the All Payer Claims Databases, where right now they're moving towards a national standard for sharing health claims data. And one problem that we're seeing there is that some of the individual states have added additional categories that they find are particularly valuable for their underserved populations. And maybe this isn't something that's so easily standardized. So it's a tough question. I hope I gave some useful insight there, though.
Yeah. Thank you so much. And I think we are out of time. But the Mansi's question, we will not be able to take it up, but I think it very clearly summarizes the thing which we are discussing. There's a contradiction between the business model and the social justice lens which you're talking about, particularly when you're talking about AI and healthcare. What business models and the pro-technology systems and the corporates would think of and envision as an AI in healthcare, and what the social justice proponent. And there should be a way to reach a mid-ground, or not just mid-ground, amalgamation of these two viewpoints to build the further systems which are more inclusive and ethical in AI and ML healthcare systems. So with this, I'd like to thank Mia and hand over to Mia for the closure. And thank you so much to all the attendees. And thank you, Dr. Jennifer. Thank you, Dr. Nova and Dr. Nimi. And thanks for staying up late. Those who are attending from the eastern part of the world, thank you so much for your time and patience.
Thank you so much, Ayushi, for bringing together such a brilliant panel. This is our first event of the year, and I couldn't have imagined a better start. I feel it's inspiring, and you just took our knowledge level to a whole another level. That I'm so grateful, and you also stayed up so late to talk to us, and we hope to see you at future events for sure. We look forward to staying in touch. And for the audience, I'd just like to say thank you all so much for joining. I'd love to share some ways that we can stay in touch. Because what we're trying to do, as you can see from the event today, we are trying to create a more egalitarian, more women-friendly, and more women-inclusive environments where women like the ones you met today at this event can share their expertise, can share their brilliance, without any mansplaining, without somebody doubting their expertise, because there's so much to offer. So we do have an event coming up in May, which we are very excited about. Please do join us. We'll be posting more information on that shortly, and it will be all about ethical AI tech and tools. We'll be inviting women speakers. Yes, we do that. We do center women in everything we do, and we'll make sure you get access to different opportunities out there. With other companies who are doing great work. You can support us. Please consider donating to our efforts, because we are a nonprofit, so you can get a write-off. We have an AI ethics newsletter, which goes out every week, so we are happy to have you join us. So all the links will be in the chat. If you don't, please reach out to us. Please do nominate yourself. We're looking to increase representation of women from other regions outside of the Western perspective. So we have a directory, so folks can reach you easily. Please nominate yourself. Do not hold back. You're awesome. You're brilliant. I believe in you. So please step up and nominate yourself. Volunteer. We'd love to have some help. This event would not be possible without our community of amazing volunteers. And we'd love to have you join us if you can spare the time and your expertise. And Twitter, we are on Twitter, Women in AI Ethics. So if you have any questions, reach out to us, get on Twitter. And I'll also stick around for a few more minutes if anyone has any additional questions. So thank you so much from the bottom of my heart. And I will just say, thank you again, and stay safe, stay healthy, and please take care of yourselves. Bye-bye.
Thank you. Bye-bye.
Thank you. Bye-bye. Good
Thanks.
night.
Thanks for the great questions, Mansi. Thanks, everyone. Bye. I think you are very agreeable. It was so nice to have you. Hopefully next time we'll have it at a better time for you. Bye. Ayushi is still there. Ayushi, fantastic job. I'm just like, okay, she's dropped. Anyone else? Okay. Thank you. We'll give everybody a few minutes to leave. If anyone has any last thoughts, pop them in there. Glad you could join us, Jasmine. Thanks for your help. Thanks, Susanna. Is that Tristy? Has Tristy joined us? Thank you, Susanna. Bye.
Thank you.
You're welcome. This was such a great event. I just wanted to take a few minutes and just say hi and say thank you.
Yes, absolutely. It was a great event. Learned so much. Thank you so much.
Me too. I'm always blown away by the quality of the speakers. Imagine like how many more women are out there who are just doing great work. And I would love to bring them all to our events and give them a platform. We have to. We absolutely have to. Is it Tristy? I don't know. I bumped somebody up and I think that's Tristy, but I'm not sure. Okay, probably not. Alrighty. Thanks, Jasmine. Hey, Maya, Ray, should we do a debrief after this?
Yeah, that works for me.
Okay, I'll call you all separately. We still have some folks in there. I just want to make sure I didn't miss anyone. Right. Okay. I can start removing folks who are still here. Susanna, since I have you, quick question. Are we doing is someone writing a post capturing some of the key highlights? Because I'm very motivated, so I can share some of my insights as well.
Okay, sure. I can do that. I think I signed up for that after
Oh,
the
you
event.
did. Oh, you're wonderful. I should stop recording now.